Hello, hello, hello. My name is Jill Osborne. I am the president and founder of the Interstitial Cystitis Network. It is Sunday, November 29th. We have gotten through one of the craziest Thanksgivings in my lifetime, and it is now officially holiday season. It is time for our regularly scheduled IC support group meeting. Of course, I am at your pleasure. If y'all don't want to do this today, I'm perfectly happy with that. If you do want to do this today, that is absolutely too. Now, my purpose in doing these meetings is to make you so strong, so knowledgeable, so informed that no one can mess with you again. I don't want anybody to disrespect you. I don't want anybody to tell you that there's no therapies for IC. I don't want anybody to tell you that there is no hope, because there is tremendous hope today. We no longer think of IC as an incurable bladder disease, and we haven't for years. We now understand that IC is a chronic pelvic pain syndrome, and some of us, myself included, actually have something called chronic overlapping pain conditions. And so, there couldn't be a better time to be diagnosed with IC today. Granted, I don't want anybody diagnosed with this. I don't want anybody suffering. But if it's happened, you can be thankful that it's in 2020 rather than in the 1950s, where they might have sent you to a psychiatric hospital, because that's what they did. IC went through a terrible period. It was discovered in the mid 1800s. If you look at the definition for IC back in the 1800s, it's perfect. In the 1920s, we saw Hunter's lesions in the bladder. They found other bladder findings in World War II. That was expanded. They got cystoscope, got better. They found petechial hemorrhaging on the bladder that they thought was potentially IC. And then these two pricks, doctors in the 50s, published a case study in which they contended that a young woman in their practice with IC had quote unquote unexpressed anger manifested in the pelvis. And that was a very dark moment for the IC community. From that moment until about 1990, medical schools actually did suggest that this was emotional. You didn't get a lot of good IC content in medical schools back then. I remember Dr. Dan Burkhoff he came out to California and spoke at a pain conference that I chaired. And he talked about how IC was an afterthought in his medical school curriculum. And that they were basically told, oh, you don't want to treat these patients. These are the worst patients in the world. All they want is pain meds. And so really the IC movement and the chronic pelvic pain movement took a terrible step back for several years because of that. But IC patients organized. The first Interstitial Cystitis Association actually organized in California. There were 3 patients of Dr. Lowell Parsons. And then a year later, the ICA that you all know today, which started in New York, also got started. And they started lobbying and got really good advocacy with our National Institutes of Health. And since then, the U.S. government has spent $100 million studying IC, and we made incredible strides forward. And nobody in their right mind could possibly say that IC is all in their heads anymore. We got physical proof. Some of you might have Hunter's lesions, which are known now to be potential viral infections in the bladder. When you think about bacterial infection, when you're thinking bladder infection, you're thinking bacteria, E. coli. How many of you think about viral infections? Well, it happens. We've now found polyoma BK, polyoma JC, and Epstein-Barr in the urine of patients with Hunter's lesions. Many others of you have IC that began after having a baby or a car accident or falling on your tailbone. And yes, you have bladder symptoms, but your bladder is a secondary victim of another injury. That, in fact, you have suffered a pelvic floor muscle injury, or maybe even a bony structure injury. One of the things that's just so interesting, we got this most amazing book exactly a year ago. Breaking Through Chronic Pelvic Pain. I'm telling you, my friends, this is the book of books. And, he brings in the concept of mechanical injury. For some of us, IC and quote unquote pelvic pain is a result of a years long dysfunction, in many cases, of bones. You have one bad hip, you got one bad knee. If you're limping, if you're pigeon-toed, if you're duck-footed, if you've got one leg longer than the other, when you're young and your body's fairly resilient, you're not necessarily going to feel imbalance or dysfunction. But as you get older, wear and tear injuries start to happen. Your body will start reacting to over the long term when you've got something that isn't quite working right or something balanced. Normally your hips would work like this, right? Bam, bam, bam. But if you got one hip longer than the other, think about the torsion that's putting on those muscles like that. So now we understand that for many IC patients, we see mechanical dysfunction. Of course, there's a big group of women who have reproductive tract issues. If you've got fibroid tumors in your uterus that are pushing on your bladder, that could cause this. If you've got endometriosis, that could cause this. If you have pelvic congestion syndrome, which is the equivalent of varicose veins in your pelvis. So if you, during the day, you're walking around and as the day goes on, your pelvis feels heavier and heavier and heavier and heavier until finally, by the end of the day, you feel like you're carrying a bowling ball around in your pelvis. That's pelvic congestion syndrome. That's really what we're going to look at with that symptom. So, we've gotten so far and so many patients are getting better. And so I'm excited to be a support group leader. I'm excited to be the national support group leader because there's so much hope now. So let me introduce myself, Jill Osborne. I'm the longest serving IC support group leader in the United States at 27 years and counting. Close to being, I think, the oldest, longest serving support group leader in the world. I think Germany's ahead of me. They might be ahead of me. Bring to you 3 college degrees, a degree in chemistry, a degree in pharmacology, drug development, and then a master's degree in psychology. And my website, icnetwork.org, which I built in 1994, was my doctoral dissertation proposal to get a PhD in psychology. And ironically, I couldn't do it because it hurt to sit in the car for years, until I got better. Because, of course, back then, nobody explained to me the concept of injury. I mean, I'm just like many of you. I just wanted to get better. I woke up one night feeling like the world's worst bladder infection. And I, like you, what did I do? I started guzzling cranberry juice. And my doctors eventually diagnosed me with chemical cystitis because I'd been in a pool accident. That was my triggering event for my bladder pain. But that said, I had issues in my 20s too with vulvodynia and irritable bowel and really sensitive skin. I'm a chronic overlapping pain condition patient, which is IC subtype 5. And so again, my purpose in doing these meetings is to educate you and to inform you. Hello, Donna. Hello, Gabby. It's nice to see you. Gabby is here from Mexico. We are simulcasting live on Facebook and YouTube. Hello, Gabby from Mexico. Let's see how we are doing on Facebook here. I didn't know. I mean, most people are still on vacation. I should still be on vacation too, but I like doing these meetings. Hello, Carolyn. Hello, Shannon. Hi, Tamara. Hello, Ruth. Yes, I'm pretty good today. Hello, Julianne. Hi, Shannon. Shannon says she needs me today. I was so stressed working at a busy grocery store on top of IC. I got my installation and found I also had a UTI. You're on antibiotics now and on the mend. Stress is a huge trigger for me. Yes, you guys, now listen. Stress doesn't cause IC, but stress will exacerbate the symptoms of IC. Stress will cause you to subconsciously tighten your pelvic floor muscles. And remember, when your muscles are tight, blood flow is diminished and you end up with ischemia, where you've got really poor blood supply in your pelvis, really poor blood supply supporting your bladder. But the other thing that happens when you're under intense stress is that does affect your nervous system. That does affect your brain to a certain degree. And so what happens is in periods of intense stress, pain will get magnified. It's part of the gating. It's actually not a gating response. It's a midbrain. It's a midbrain response in the overall pain response. And so if you are under wicked stress and you're really anxious, your brain is going to intensify that pain because it thinks your life is in jeopardy. Whereas if pain is accompanied by laughter, your brain is going to minimize that pain. And so it is really, really, really important for any of us who struggle with pain to try to keep stress out. We really got to work and polish our stress management skills, and even more importantly, our anxiety management skills. And again, nobody's saying that this is mental in any way, shape, or form. All we're saying is that will exacerbate it. And remember, God didn't give you the skills to deal with when you were born. You got to learn them. You got to learn good stress management tips. You got to learn good anxiety management tips. I've got a really good video over on our website, icnetwork.org, about the anxiety management class that I took 20 years ago that absolutely changed my life. And, gotta say, for those of you who know, I care for my elderly parents. My dad is 98. My mother is 91. She'll be 92 in February. And it is stunningly stressful because I know that on any given day, this could be the last day, and I am the person here. And it is, I can feel the little worry, the little stress thought. It's like, is he okay? Is this, and I use my system: stop sign, deep breath, minimize the thought. If I have a negative thought, the first thing I do is I'm going to visualize the stop sign, just like stop for a moment, breathe in for 3, and minimize the thought. Just like, I'm not God. I can't predict the future. I'm not going to agonize over the fact that let's say, what do I normally say? I'm not God. I can't predict the future. How arrogant can I be to think that I can predict the future? I give myself some sort of reality check. It's a thought. It has no power. And I really, really, really try to nip negative thinking as quickly as I can, because I know that will overwhelm and trigger my nervous system. Hello, Bola from Manchester. Is it England? Nice to see you, Bola. Let's see. Hello, Boria on Facebook. And you guys, if you find these meetings helpful, it would be really great if you came on over to our website and became a member so that you can get our wonderful magazine. I'm working on the fall. I'm combining the fall and winter magazine into a big double issue. And that's why you don't have your fall magazine yet. Plus, we had the fires and everything was delayed for 6 weeks. But anyway, I'm working on it. I promise. Hello, Debbie from St. Louis, Missouri, who is on her way to Gulf Shores, Alabama for 4 months. Had Hunter's lesions fulgurated in August, pain and symptom free for 3 months. Yeah, baby. Woohoo! Yes. Now listen, when people call my office sobbing in pain, because I do patient coaching almost every single day, the moments that piss me off the most are patients in agony, and they've been diagnosed with Hunter's lesions that they were never treated. Now listen, guys, the Hunter's lesion is a big bloody wound in your bladder. It hurts. And again, we think that's probably a viral infection or a really bad nerve inflammation at that location where the wound is. Hunter's lesions respond beautifully to therapy. If you laser it, you can cauterize it, you can inject it with a steroid, and 85% of the time your pain is probably going to go away completely. And so if you are going to have a hydrodistension, it's important that you have that discussion with your doctor. What are you going to do if you find a Hunter's lesion in my bladder? And if the doctor says nothing, I would get another doctor. And I would say, why? I mean, I don't, you're looking, I'm in pain. You're looking at my bladder. You're looking for dysfunction. If you find a Hunter's lesion, which is considered the most severe form of bladder injury, why wouldn't you treat it? I need you to treat whatever you find. And usually it's because they don't have the equipment and in the OR, or in their office. Well, no, a hydrodistension is always done in the operating room. But usually that means that they simply don't have the equipment or don't know or have not been trained. And if that is the case, I would, in my opinion, step back and say, I need to work with somebody who is capable of treating this. Because we have some patients who have had untreated lesions for a decade, and they've been in agony for a decade. And they're stunned when they actually get their lesion treated, how much better they feel. All right. So Debbie said you're getting a little bit of pain back, but not too bad. Okay. So Debbie, now listen, maybe it's probably just stress from the travel. When you're driving, you were getting a lot of vibration on the pelvis. That's going to trigger the bladder. That's going to trigger the pelvic floor. Let's just throw in the holidays in general. Guys, holiday stress is real. Bola says, yes, she is from England. Hello, Bola. I love England. And I love Scotland, and I love Ireland. I always felt growing up as a redhead here in California that I never belonged, because I wasn't a blonde. I remember I was I was a pretty successful tennis player and actually turned pro briefly while I was in college. And I was hired without an interview or pictures to teach us tennis for the Welby Van Horn tennis camp that was located at Choate Prep School in New Haven, Connecticut. And no, Wallingford, Connecticut. And at that time, I had a pixie cut, short, dark red hair, and I was like so skinny, I looked like a skeleton, right? Because I was really competitive. I walked in and their jaw dropped and they were like, what? They were expecting, a beautiful blonde, tan girl. They were not expecting a tall, skinny, gangly redhead. It was hysterical. They didn't fire me. That was good. I did get that job for 3 months, but had an opportunity to play with really good tennis players, which is awesome. Hello, Joan from Buffalo, New York. Brenna says, I've been in a flare since Thanksgiving. You're miserable. Brenna, what do you think triggered your flare? Hello, Carolyn, also from England, from Dagenham, England. Hello, Charlene from New Zealand. Gosh, you guys, it feels very international today. And Charlene, I hope now that you guys are in the middle of your fire season that we're just coming out of. I really hope things go well for you guys this year because summers are brutal. Hello, Laquette. Laquette is having a cystoscopy with hydrodistension tomorrow. All right, Laquette, I'm going to absolutely wish you well. Lots of deep breathing beforehand. Deep breathing. You can do this. I am in support of having a doctor look inside your bladder. I was working with a patient last week who had been in worsening discomfort for a couple of years, and she was afraid to let somebody look in her bladder. And I'm like, now listen, you're forcing everybody to guess. If I'm in pain, I want somebody to look at where it's hurting. Can you please tell me what's hurting and why? What is the problem here? If you don't let them look in your bladder, you are forcing them to guess. And frankly, I think you deserve more than a guess. Now, granted, hydrodistensions are they're no longer critical for a diagnosis of IC. They're only meant to be done if a diagnosis is in doubt. So generally, when you go through the diagnostic process, the assumption is you've had symptoms for three to 6 months. They can't find any other obvious cause. And normally at that first appointment, they will take your history. They will do a pelvic floor examination. They will do a really good urine examination. And then generally what they will do, unless there's something really different, like you've got blood in your urine, which most patients don't have visible blood in your urine. But if there's nothing that alarms them, they will normally give you the diet, tell you about the supplements, some of the first line interventions, and send you on your way for 3 months. And they say, give that a shot for 3 months and then come back. And of course, you're walking out of there going, what? You're giving me a diet? What? And the reality is that for a lot of you, your bladder is injured, it's wounded, and it needs time. And the reason why they give you the diet is so that you don't interfere with the healing process. So if your IC began because you went through chemotherapy, or your IC began because you just drank way too much diet soda or soda, and eventually your bladder wall just got fried, or if you are of a certain age where your bladder is more vulnerable anyway because of estrogen atrophy, then that's actually the right thing to do, is to give you the diet to help you avoid the foods which will irritate your bladder more, and then give you perhaps some of the supplements like Cysto Protect, Bladder Builder, Cysto Renew, Cysto Mend, one of those, and just give your bladder a little bit of time to calm down. And I know that we're programmed to think it must be infection. Please give me antibiotics. But the reality is, guys, it's not infection for almost all of us. I've only had in 27 years 2 legitimate infections. And yet I probably had 50 urinalysis because I was convinced that I had infection. Remember, the bladder only knows one language: frequency, urgency, pressure, pain. You could have a bullet wound and it would feel like infection. You could have a stab wound and it would feel like infection. Everything feels like infection in the bladder. But injury happens. The bladder can be injured like any other part of the body, and generally it's injured through some sort of chemical exposure. Donna says, I'm a rebel. You bet it. You better believe it. I had my blog, my IC blog for a while was called the IC Underground. Bola says, thank you for the channel. I've learned loads. Here in the UK, you feel alone. No medicine prescribed for me. I'm just left to sort myself out, but your channel has educated me. Bola, hun, I'm so glad that we can be here for you. And please know that there is a United Kingdom, I think it's Bladder Health UK, is the nonprofit that works with bladder diseases. They originally were the United Kingdom IC support group run by Anthony and Annette Walker. And then things happened, things moved on. There was some pretty serious conflict between European IC groups and the British IC group. They all got fighting terribly. It was really sad. And the United Kingdom group became the Cobb Foundation, the Cystitis and Overactive Bladder Foundation. And then it almost died. And the board of directors were getting ready to shut down the United Kingdom IC group when a new group of patients stepped forward and resurrected it. And so the current iteration of the Cobb Foundation is now Bladder Health UK. And they are a great resource for patients who have IC. And they have a nurse who answers the phone, I think 1 or 2 days a week. So you can actually call them. So make sure you search for Bladder Health UK. Carolyn says, how do I join? I join what? If you want to join the IC network, you just go on over to our website and click on our store and go for a membership. Hello, Larissa. She says, I am new here. I am glad I found you. I am in Upper East Tennessee. Yes. 3 weeks post-op, permanent InterStim implant for my IC. What are your thoughts on this treatment? Oh, Larissa. Ooh, isn't that opening a big old giant can of worms? I was actually the support group leader here in Northern California when InterStim was created. It was developed at UC San Francisco by Dr. Richard Schmidt and Dr. Tanago. And those early days were brutal. They were absolutely brutal. They had leads that moved if you sat down the wrong way. The biggest problem with InterStim back then, and again, we're talking 25 years ago, was the fact that they didn't use anesthesia when they did trials. And so I had patients in my group. I had one mother who was there with her teenage son, and the doctor said, hey, we got a new treatment, InterStim, you want to try it? And the mother's like, is it safe? He's like, yeah, not a problem. She looks at her son, the son looks at her. It's like, all right, let's give it a shot. About 20 minutes later, she could hear her son screaming from one of the medical rooms because they were trying to do a trial with zero anesthesia. And let me tell you, did that piss me off? And so I led an effort to Medtronic to demand that they change that, because that young man was, I think she said he didn't talk for like weeks after that. Like he literally didn't speak. It was so traumatic for him. It was torture. So there's a lot of early controversy with InterStim. Dr. Richard Schmidt ended up moving to the University of Colorado, where he tried to continue his InterStim research. He was fired by the University of Colorado. not once, but twice. He filed a grievance over the first one. They paid him out of their litigation avoidance fund for a year. They convened a panel of experts for a second time. They also recommended that he be fired, and he was fired for unsafe. According to the lawsuits, there were a whole bunch of lawsuits that were filed in the state of Colorado against the university and against Dr. Schmidt on behalf of InterStim patients. Now, since that time, Medtronic had acquired InterStim, and then they brought in some really, really good doctors, like the top InterStim surgeon, in my opinion, is Dr. Ken Peters at Beaumont Health, who is also the top IC researcher in the United States. And the reason why he's so good is he's absolutely meticulous. Where some doctors might take 30 minutes to do it, he takes 90 minutes to do it. He's really careful. And so his success data is the data that was used to garner it through FDA approval. Ultimately, Larissa, you have to understand that InterStim requires constant maintenance. There is a place for InterStim. I am not against InterStim. What I think is very important that patients understand the logistics of having neuromodulation on the pudendal nerve or on the sacral nerve. And you've been there. You are 3 weeks post-op, so you know what it's like. InterStim is FDA approved for overactive bladder, for frequency, urgency. It is not FDA approved for pain control. But you got to be on top of it. It's really important that you be on top of it. If there are any issues, if you ever feel like you're being shocked, like I had one woman who was shocked every time she had a bowel movement, and her doctor told her that was normal. That's not normal. And I got that woman back to the company and they said, yes, that's not normal. So if you feel anything weird, if you go through a security gate going into a courthouse or at an airport and you feel something change, that's important because that's how the device can be accidentally triggered. And that's usually how it's triggered. If you notice that your lead moves, if you notice any pain down your legs, and the most common issue post-operative with InterStim is a MRSA infection at the site of the where they put the unit in, where they put the generator in. And so if you have tenderness on your scar, if you have any tenderness in your butt cheek or in that muscle group, it's really, really, really important that you let your doctor know, because there are thousands of adverse event reports filed with the FDA about InterStim, and the most common issue is, in fact, MRSA. In fact, I haven't counted them. I mean, God, there have been 20 years. I mean, it's been out for what, 20 years, right? Maybe more than that. The last time we looked, it's like 50 adverse event reports a month. We just looked at it a couple of meetings ago. So just be on top of it. Talk to your doctor. If anything feels weird, be assertive. Say, this is not right. Because the challenge here is that, doctors are like, well, you're just in your post-op recovery. Maybe we just need to reprogram it. And so what happens is patients keep going back and saying, it doesn't feel right. It doesn't feel right. And the doctor reprograms, and it still doesn't feel better because sometimes there's a fundamental flaw with the actual implant procedure, like a MRSA infection. But it can be life-changing, especially for people who are incontinent. I mean, InterStim shines for people who have bowel incontinence or bladder incontinence. It can absolutely change their lives and completely take away their incontinence. So it's fabulous in that respect, but it's you're on a journey now. Hello, Deborah. Hello, Debbie. Ellen, I had a colonoscopy on Friday, and as soon as I woke up, I had to go to the bathroom. I knew something was different about my bladder. My bladder hurt for a week. Do you think it had anything to do with colonoscopy? Well, ironically, my sister just had a colonoscopy last week too. Colonoscopies are going to cause your pelvic floor to spasm. Well, remember, what do they do? Aside from cleaning you out, and of course, some of the prep solutions can be pretty high in irritants. And so you could have some residual irritation of your bladder from the actual prep solution. But as they go in there and they take a look, and we are thankfully asleep, and we don't know anything, thank God. They use a little bit of air to kind of open up the tube so that they can look. So that will cause some cramping for several days afterwards for some patients. And that was something my sister was noticing, that she had more cramping, especially the day afterwards. So that, of course, is going to trigger your pelvic floor. You know, I can't imagine how your bladder would be directly harmed by colonoscopy. The only context that I can think of, it would be just a gross error where let's say they removed a polyp, and as part of that removal, they perforated the intestine, which then could have perforated your bladder. That would be the only context. And I know that that's happened, but it's really, really rare. I mean, that's really a sign of a very, very unskilled doctor who doesn't know what they're doing. So hopefully things will calm down. Drink plenty of water and try to dilute your job is to create let's operate on the assumption that your bladder was irritated by the prep. So your job is to create an environment to support healing, right? So you got to follow the diet, drink water, drink chamomile herbal tea, peppermint herbal tea. Peppermint herbal tea before a colonoscopy has been proven to reduce bowel spasms. So I would do things that would be a smooth muscle relaxant like chamomile herbal tea, peppermint herbal tea. And then, maybe to kind of comfort and soothe your bladder a little bit, you could try aloe pad. Let's see. Where is it? Here it is. Aloe is known for being kind of calming and soothing. And so if this is kind of a transitory irritation, then you could maybe try something with a little bit of aloe in it. And the reason why, we really like Allopath is because it's aloe combined with PEA, and PEA has been found in a major IC research study to reduce pain in IC. And so this is the aloe that we now suggest that patients try, Allopath. And you can find this and the other supplements right on our website in our store. Brenna says, most of my pain is in my urethra. Girl, all right. This is my bread and butter. Let's talk about urethral pain for a moment. So I have a great blog on our website, the 7 causes of urethral pain that that Brenna, you need to look at. But generally, we're going to look at a couple of major things. So the first thing we have to look at is estrogen atrophy. Because, your urethra, let's see, how can I explain? I want to explain this the right way. A lot of people are surprised to discover that your urethra and your bladder are mucous membrane covered organs. And think about it. They're the only organs in the human body designed to hold toxic waste because urine is body waste. So how the hell is the bladder going to protect itself from ammonia and urea and acids? And the answer is it protects itself with a really thick, robust coating of mucus. We call it the mighty mucus. And so you've got your mucous membrane organs are your mouth, your vulva, your vagina, your urethra, and your bladder. The urethra, though, unfortunately, mucus production is estrogen dependent. So when you're young and you have lots of estrogen, you have lots of mucus, and you can get away with stuff. When you're older, you have much less estrogen, much less mucus. Thus, your bladder's ability to defend itself is now compromised. This is not a disease. We don't look at this as a disease. This is just aging. Things are getting dry. Well, unfortunately, the urethra is kind of the canary in the coal mine when it comes to estrogen atrophy. It's the first part of the urinary tract to start responding to the loss of estrogen. And the urethra becomes quite irritated. It happened to me when I was like 51, somewhere in there. It felt like there was a drop of urine stuck in my urethra that would not come out. And it just became very irritated. And guys, I threw everything I knew. Listen, my IC skills are really good. I mean, obviously, I wrote the website and I've written books on this. And yet, everything I threw at this urethral pain was ineffective. And so I finally threw myself on the mercy of my urologist. And I've told this story. I probably tell this story at almost every meeting. So here I am laying on my back with my knees spread, and he's looking down there and he goes, "Jill." I'm like, "What? What did I do? What?" He goes, "Didn't you use the hormone cream I prescribed for you last year?" And I went, "No." And he goes, "Why?" And I said, "Because of my brain. I'm 25 years old. I can't possibly have an age-related issue because I am still 25 up here." And he explained that the bottom half of the urethra is remarkably sensitive to the loss of estrogen. And so, Brenna, the first thing we have to look at is your age. Now, what they recommend generally in that context is that they give you a little bit of topical estrogen cream and you rub a pea-sized drop right into the entrance of your urethra, which is what they had me do. And within 10 days, it was gone. If I forget to do it for 2 weeks, it comes right back. And so I'm extremely invested in using my topical estrogen cream right at the entrance to my urethra. The second thing we have to look at is chemical irritation. If I put on a pair of underwear, wash and tied or cheer, my urethra, my vulva will start burning. And again, that's because my skin can't protect itself. It's dry and the chemicals are irritating. We have to look at fabric softener. It's going to do that. Some sort of chemicals that are going to irritate the urethra because the urethra, again, can't defend itself. We're going to look for tight pelvic floor muscles because you do have pelvic floor muscles that wrap around your urethra. And if your urethra, if it feels like you can't start your urine stream right away, or when you're peeing, your urine stream is narrow, like you're peeing through a needle, that probably means that you've got tight levator ani muscles. And I can explain. Let me show this to everybody out there so you all understand. So, what makes the pelvic floor muscles all the more important in human body functioning is that they're the only major muscle group that influence major bodily functions. Because they're basically, for women, 3 holes. There's a hole for the urethra, there's a hole for the vagina, and there's a hole for the rectum. And you can see that right here, right? So look at this. So we have a rectum, we have a vagina, and we have a urethra. But look at the muscles right here. You got muscles that go right here. If these muscles are tight, bam, your urethral opening is going to get tight. Your urethra is going to get tight. Your vagina, it's going to be hard to pee. It's going to be hard to have a bowel movement, and it's going to be hard to have sex because the muscles are just in a constant. They call it hypertonic muscles. And so some women are diagnosed with urethral syndrome or a urethral stricture, and doctors like to go in and just stick a metal rod in there and stretch it without asking the important question, why is it tight? And that's why pelvic floor assessments are really, really important. And then one of the other things that we look at is that your urethra is about the size of your little finger, right? I mean, maybe a little shorter than your little finger. About halfway up is a gland that's wrapped around the outside of the urethra. It's called the periurethral gland. It's like a sea sponge. And it is the female prostate gland. We have a prostate. And when they sampled the tissue of the female periurethral gland with the male prostate gland, it's identical. So we have a little tiny prostate gland. And like the much larger male prostate, our little gland can get infected. And so imagine that you would have an infection halfway up. Now, but you can easily rule this in or out, because if you stick, let's see. So if I take this off for a moment, well, this doesn't work. If you stick your finger in your vagina about an inch and rub across the front, if you feel what feels like a deep pimple like a deep, painful pimple, you could have an infection in your periurethral gland. That's pretty rare, but I've worked with several patients who have had them. And what's interesting about these infections is that they include what we call heterogeneous populations of bacteria. Not just one bacteria, it's a whole bunch of different types of bacteria living together in the female prostate gland. So come on over, Brenna, come on over to the website, icnetwork.org, and just search for urethra or urethral pain, and you can find that blog and go through that, okay? Let me drink some water here. Does anybody notice? I notice that if I drink water like this, I swallow air. And then my stomach gets, full of air, and I don't like it. So I'm using a straw more. And it's working for me. It's the little things that count, right? All right, let me check YouTube here. Hello, Lisa. Happy Sunday to you. Hello, Kiana. Kiana says, I am in a severe flare right now. My urologist that I've been with for 5 years says she doesn't want to treat IC. I was told to be quiet when describing symptoms. Oh, well, screw her. Are you kidding me? Well, I mean, listen, if she says she doesn't want to treat IC, then ask for a referral. Go to somebody else because you deserve better than that. That is terrible. Absolutely terrible, Kiana. And I am so sorry that doctor happened to you. But guys, now listen, you got to understand, as when I started this meeting off, I talked about the checkered history of IC, that there were years, unfortunately, again, starting in the 1950s, where medical schools taught that this was not real, that this was a mental and emotional condition. And we know that that's absolutely not true. We know it's real. We got the research to back it up. We $100 million into IC research proving that. But because of that legacy, whenever you go to a new doctor, seriously, do not walk in and say you've got IC. Do not do that. You're going to fall down the rabbit hole. That is not helpful to you, and that is not helpful to the doctor. You need to walk in and say, doctor, I am here because I am trying to understand these weird symptoms that I'm having. And then you got to describe them. And your ability to describe them is going to determine how good that appointment is. So you can't say, it hurts down there. Seriously, be specific. Where? Does it hurt inside of your body? Does it hurt outside of your body? Where does it hurt? Is it in the center? Is it to the left of center? Is it to the right of center? Is it shallow down by your urethra, or is it deep? Do you have pain by your belly button? Do you have pain by hip bones? And then do you feel anything weird, like a buzzing sensation? Do you feel a vibration? These are all symptoms that will help that doctor understand your unique anatomy. So please don't walk into any new doctor and say you got IC. Say you're here because you're trying to understand why you have these symptoms. We don't want you to jump down the rabbit hole. And you got to do some work before then. I mean, start taking notes. What triggers the pain? What makes you feel better when you have the pain? Does the pain change throughout the day? Were you fine in the morning, and then as the day got worse, the pain got worse and worse and worse with this heaviness feeling? Well, then we know that that's probably congestion syndrome. Did you sleep well, but as soon as you sit on the side of your bed, it hurts? Well, that's probably pudendal neuralgia. And so you've got to kind of look for patterns. And how does it change throughout the day? And look for the little weird symptoms. There are always going to be little weird symptoms. The symptom that you just do not realize how important this symptom is, like this little fluttering feeling called a fasciculation, or a little vibration. Or if you've got what I call one of the dirty secrets of IC, where you have moments when you feel like you're aroused, but it hurts. That's actually pudendal neuralgia. That probably means you have muscles so tight they're squeezing that nerve, the pudendal nerve that innervates your clitoris. Let's see. Bola says, sure. Bola, her husband has a question. I'll take it. Happy to take it. Kiana says she lives in Louisville, Kentucky. University of Kentucky has done some IC research in Lexington. Deborah Erickson, but I think she might have just shut down her practice. Louisiana. Hello, Louisiana. My urologist doesn't want to treat my symptoms based on microgen testing. I did the test. He agreed to one treatment and tested again, and the findings were half. You know, Louisiana, and I love your first name, Louisiana. That's awesome. At this year's American Urology Association conference, which is the largest urology meeting in the world, and of course it was all virtual this year, there was a very important keynote speech by Dr. Curtis Nickel on next generation testing. And he was very clear in saying that next generation represents the future, that it will be used more and more aggressively because it's so much better at identifying weird infection as well as drug-resistant infection. And of course, it will also identify fungal infection and even viral infections in the bladder. And of course, we now have research that shows that many patients are flaring because they have candida in their urine. They have a fungal infection in their urine, which makes sense because so many of us have been massively overexposed to antibiotics. So of course we do that. So if you notice that you flare when you eat sugar, then you probably have a candida infection. The challenge is that the local doctors really don't know what to do with it. The data intimidates them. They don't know how to interpret it. And interpreting next-gen testing is hard anyway. Because basically, you'll get a list of bacteria: Lactobacillus, E. coli, Enterococcus, Actinobacter, staph, strep. I mean, it's amazing the list you'll get. But here's the deal: urine is not sterile. They've now identified, I think, I want to say 4,000 potential living beings in our urinary tract. And I think in the IC world, now again, they're still trying to define what's a normal biome. We really still don't know what a normal biome is. But I think that in the IC studies done by the MAP Research Network, I think they were focusing on 300 different bacteria and variants of these 300 different bacteria. And in those next-gen studies, and I know I've gone over those in our magazine, they have been able to implicate certain bacteria in certain urinary diseases. As an example, if you've got kidney stones, there is a bacteria that normally processes oxalates. And though the purpose of it is to destroy oxalates. But if you've taken antibiotics and you've destroyed that bacteria, your body can't process oxalates anymore. And what happens? You grow oxalate kidney stones. So it's very new and exciting, and we're learning a lot about it. But it's still early. So you could potentially call the company and see if they can refer you to somebody else. I think the problem is and I interviewed the CEO of Microgen is Rick. I don't remember what his last name is. And I asked him about that because sometimes what happens is patients end up chasing infection. You have a Microgen test. It says, yes, you got, 50% E. coli, you treat that, you go back, you have a Microgen test, and then it says you got Enterococcus, you treat that, you go back, and then it's something else, and then it's something else, and then it's something else. And that's really showing the dangers of antibiotic use to a certain extent and how that disrupts everything. When you take an antibiotic, it's like putting a flamethrower in a tropical forest. It kills everything. And then we've lost all of our normal balance, and we need that balance. So what Rick said is that rather than chasing infection, we've got to look at, because we don't necessarily still understand what's normal, you have to look at two factors. You have to look at what do they find and what are your symptoms. So if you are symptom-free, but they find a little bit of E. coli in there, but you're symptom-free, then maybe that E. coli is supposed to be there. Or even though E. coli is considered a pathogenic infection, listen, we've all got E. coli all over our bodies. Normally, it's just really, really controlled. So what he said in that interview is if you have active symptoms of infection combined with a microgen test finding a weird growth of any number of bacteria, that's when you treat. But if you are symptom free, but you test and you're finding something, a weird combination like lactobacillus and E. coli and then enterococcus, maybe that's supposed to be there. Maybe that's your biome right now. I've had 2 microgen tests, and I didn't treat either one of them. I didn't treat either one of them. And they both found, one of them found Enterococcus facialis, which is a really challenging Enterococcus, but I wasn't having symptoms. I did it because I wanted to learn about the process so that I could talk to you about it. And I have my test results somewhere. I could show them to you. Kiana says, I've done pelvic floor physical therapy, and my next appointment is the 13th, so definitely taking steps, and I have a list of notes on my phone. Awesome. Good job, girl. Good job. So Louisiana, again, if I would say, then what do you think's causing my symptoms? What's causing it? What do you think is causing this symptom? Yeah, he said he was just going to treat the symptoms. Well, that's really not helpful. I'd love to see the test results. I would love to see your test results. Did it find anything weird? Let's come back to Facebook. Hello, Laquette. I'm sorry if I didn't pronounce that correct. Laquette? Is that right? Hello, Marta from Norway. Hello, hello. I have family in Drummond. Hello, Jenna from Cincinnati. Hello, Larissa. Brenna says, makes sense. I'm in perimenopause. So Brenna was having urethral irritation. Right, girl. Yep. Melissa says, I've been on oral hormone replacement therapy for years. Recently, my gyne prescribed estrogen cream at the recommendation of my pelvic floor physical therapist. Is it okay for me to be taking both forms of estrogen? I have my uterus, no history of cancer, normal blood pressure. Well, hon, that's, I can't give you medical advice. All I can do is give you context. And then I've got to kick you in the butt and get you back to your doctor so that you can have a good discussion with your doctor. What I can tell you is that topical estrogen, and you can Google this, the research studies for topical estrogen show extremely low risk. In contrast to oral estrogen has much higher risk. And if you followed me at all, Melissa, then you should know that 3 years ago, I started spotting. And over a 6-month period, it got worse and worse. And I ended up having early uterine cancer. And I had to have an emergency hysterectomy. I chose to take oral estrogen because nobody in my family, we had no history of any estrogen-driven cancers in my family. None. Zero, zip, nothing in my family. And so I thought I was safe because I really thought genetics played a critical role in breast cancer and things like that. And I asked him, I said, why me? Why would this happen to me? And he goes, Jill, it's not about genetics. It's about you just having cells that grow with estrogen. And so Melissa, I would Google it, learn a lot about, the pros and cons of oral hormone replacement therapy. Do I regret it? No, I don't regret it because it helped me work and I needed it at the time and I felt great because menopause was, I thought, pretty rough. I miss it. I have aged tremendously now that I haven't done it for 3 years. Like, hello, chicken skin right here. Like, holy moly, did that happen quickly? If I could take it again, I probably would like to take it. But when I talked to my gynecologist about it, I said, what are the risks? I had early uterine cancer. Could I also get breast cancer? And she said, yes, there's a group of people who get both, which is why I did not restart it. Barbara, is there any information where I can find a list of urologists you recommend that are familiar with IC? Yeah, hun, right on our website, icnetwork.org. icnetwork.org. There's right in the main menu is find a doctor. Just go there and you can put in your zip code. Florida is a tough state. I'm going to tell you right now, Florida is definitely a tough state to be in. It used to be an outstanding state for IC. There was an incredible network of support, IC support groups down there, but they all basically disbanded. If you're down by Miami, there's a new IC support group in Miami that's quite good. And you can find the support group list on our website too. Joan says, your prescribed medical cannabis oil seems to control my IC for inflammation. My doctor claims that many of his patients get relief from CBD. Yeah, absolutely. We did the longest CBD THC study in the IC community. We did it for almost 8 or 9 years, and it's an absolute fact that it can help. Brenna says, wow, I'm 44. It gets worse before my period. So, Brenna, understand that when you start using a hormone cream, the odds are it's probably going to feel hot, like it's burning you. And it's not burning you, but what that's speaking to is the quality and health of your skin. So, a lot of women are really surprised when they start using estrogen cream, how uncomfortable it can be at first, especially Premarin. We don't recommend Premarin because there's a lot of extra preservatives in it that can be irritating. But the fact of the matter is that if your skin is dry, any chemical you put on it's probably going to be a little bit uncomfortable at first. And so it took about 2 weeks for the heat to go away for me. I mean, when I first started using estrogen, use a compounded estrogen, propylene glycol-free estrogen cream that I get from the Women's International Pharmacy, which is a wonderful mail order pharmacy that specializes in hormone products for people who are sensitive. And it was hot for the first week to 10 days, but now it's like a little warm puff of air. So Carolyn says, I asked for estrogen cream once. Doctor wouldn't give it to me. This was while I was back, but I sure need it now that I'm 60. Yeah. I mean, like I've worked with some ladies who by the time they're in their 80s, their little vulvas are like dry potato chips and they're in agony. The quality and health of your skin matters. The quality and health of your skin, of your mucous membranes, matters to bladder function. And as it gets dry from estrogen atrophy, your bladder is going to get more vulnerable. And again, it's not a disease. If you've got estrogen atrophy, you're going to probably want to do things in addition to estrogen, which would allow your skin to immediately start producing mucus. What we would be looking at is something that contains chondroitin, using a supplement that would give the bladder a bit of an extra coating effect makes total sense for somebody with estrogen atrophy. And we had a research study presented earlier this year that showed that chondroitin was the most effective at restoring the integrity of the bladder wall. And so those supplements would be I chipped my front tooth again. You see, I got these chips. It kind of hurts a little bit. Oh God. I might come back with perfect front teeth one day. Just don't want to go to the dentist quite yet. It all started with a Tootsie Pop. It started with a Tootsie Pop 20 years ago on Halloween, and I cracked right there up the inside. So annoying. Okay, so the chondroitin-based supplements are going to be Bladder Builder or Bladder Rest or Cysto Renew or Cysto Protect or the new one, Cysto Mend. And you can read about those on our website. And what's cool about these is, number one, the American Urology Association encourages patients to do the supplements before you try traditional therapies. They're listed in step 1 because they carry so fewer risks than traditional medications. They would have given you Elmeron in years past, but we now know Elmeron is linked to eye disease and retinal disease, and even some patients are going blind from Elmeron. So since we don't have another oral medication that will provide that protective effect. It's really about the supplements, and the American Urology Association absolutely supports their use. They don't recommend brand names, they never do, but these are the core supplements that are used. Patty says, tight pelvic floor muscles, my issue at this moment, past 2 days, had massive tightness that nothing would ease. So heat, sitting in a warm bathtub, using a muscle relaxant. If you've got some Flexeril or some Baclofen, using maybe some gentle stretching. If you've been working with a pelvic floor physical therapist, hopefully you have a wand and you can go in there yourself and use that wand to try to release those muscles. That's what I do when I feel those muscles start to tweak out. When I say wand, I mean this. So hopefully you have one of these. You can get these on our store, and where you can get in through your vagina, or for men through the rectum, and you can actually massage those muscles down. And let me show you what we're trying to accomplish here. So when people say pelvic floor muscles, the immediate assumption is, okay, they're muscles at the base of the pelvis, but they're not. They actually go up the sides. And you can see this, right? So here's the base down here, but look, you got muscles on the sides, and you got muscles on the sides. If you have sciatica, if you got pain shooting down your leg, then that's from tension in one of these side muscles. And so generally what a physical therapist will do is they will follow the length of the muscle. See that? See how I'm following the length of the muscle? Because if your muscles are tight, they're going to be cramped up like this. So the best way to do it is to get them to flatten down and drop down by following the length of the muscle. And it's kind of a J shape. I don't know if you can see that. You can see it's kind of a J shape. And so this is what the physical therapist is going to do. Is they're going to follow these muscle groups, and they're going to be able to reach all the way over to the inside of your hip bone. You can too. So they're going to actually be pushing right up against this bone. It doesn't hurt at all. It's just really fascinating what they're doing. And if you have a wand, you can stick your wand in there, and it will just help you access it a little bit more. And honestly, I didn't know what the hell I was doing with this the first year. I mean, I really didn't. And my physical therapist kept saying it's a J shape, it's a J shape. And I didn't get it. It just it doesn't make sense to me that it's a J shape. But once I got that book, I totally got it. It's like, okay. And so when you're laying on your back and you're using it, it's important that you be able to visualize what muscle you're stroking. And all I can tell you is it works. It works beautifully. I know for me, a lot of my pain is on my left side, but when I get in there, it's my right side that's really, really tight. And that's just showing that this side is tight, this side is weak, this side is pulling on it, triggering pain, but I still have to get rid of this one. I've got to loosen that one too, right? Barbara says, have you heard about the InterStim Micro? Yes, I have. I don't have any comments on it, though. I don't really have any patients who are talking about it yet. They don't know what, Medtronic doesn't know what to do with me, because they know that I ask really hard questions. Like, what are the risks and side effects and long-term side effects? And I like follow-up reports, FDA reports, things like that. They don't like to show that stuff. Hello, Sherry. Ashley, is it good to take antibiotics when a very bad flare? No, it's not, unless you've got data supporting it. So Ashley, if you, for example, have used a UTI test strip, and that UTI, so let's just say it's a Saturday and you're having a wicked flare and you have a UTI test strip, and if that comes back a double positive, then that's strongly suggestive of infection. But the problem is that if you take the antibiotics before you do your urine culture, you're not giving them an opportunity to identify the infection. And so it's tricky. It's tricky. We don't recommend self-medicating with antibiotics with flares. You got to try to figure out what kind of flare it is. I mean, what do you think triggered your flare? Number one, was it flying? Was it traveling? Was it sitting in a car? Was it sex? Was it bad food? And then go accordingly. Everybody, if you come on over to our website and you sign up for our free newsletter, which you can do right on our Facebook page, you can download our 40-page flare management guide, which has hour-by-hour rescue plans for the different types of flares you can have. C says you have severe urethral pain. Doctor put you on Lyrica. Okay. Well, again, Cease, I would want to know the quality and health of your skin and make sure that estrogen atrophy is not playing a role. Lyrica certainly calms nerves down. And yes, you have a lot of nerves by your urethra. So that's not necessarily a bad thing. Getting off of Lyrica can be a little bit hard. It can cause a discontinuation syndrome. But ultimately, we want to look at the skin and make sure the skin's really healthy too. Julie says, my daughter has COVID and is so stressed. She's all alone. Oh, I'm so sorry. So we've been doing a survey. We're the only group doing, trying to follow IC patients who have COVID. And I just looked at the data last week, and 81% of the patients in our survey report that they flared with COVID. And we don't know why. We just don't know why yet. That the flares seem to be improving, but some patients whose IC were completely controlled and they hadn't had flares for years suddenly flared when they got COVID. Lisa says, I'd like to discuss your article from the late summer IC Optimist, your article on Ehlers-Danlos. That's me. What's your question, Lisa? I don't know that much about it, and I did not write that article. Nan says, how do you recommend taking or applying CBD for TIC? Generally, it's usually going to be as an edible rather than as a vape, because when you smoke or vape, there are toxic byproducts from burning that will end up in your urine that will potentially irritate. So IC patients tend to prefer edibles. If you are going to do an edible, always, guys, you have to ask the company for testing to make sure that the medical marijuana that they're using is not contaminated with pesticides. Patty says, I ordered a wand yesterday and plan on having my PT teach. Awesome. Lorraine says, it's also overwhelming. So many products and supplements, and you do not know if any of them will work. Lorraine, that's why subtyping is so important. We cannot have a good discussion about what your treatment options are until we understand your unique anatomy. So if you are a chemotherapy patient and the chemo's irritated your bladder, then we're going to be doing things that are going to calm and soothe your bladder. And so some of these supplements might be real. But if your IC was triggered by having a baby or falling on your tailbone, then we're not going to be doing a chondroitin-based supplement. It's probably going to be Peora or something that might have a pain-reducing effect. Look at that. I'm actually on time with my Facebook. Normally, I'm 30 minutes behind. Holy moly. So normally what I do is I break this meeting into 3 sections. So we do an intro where I tend to do a little bit of an educational thing. Didn't really have anything prepared today. And then we go into a Zoom meeting, and I might start the Zoom meeting early. Hello, Nan. Nan says, what am I drinking? It sure looks like lime. No, it's passion fruit Gatorade. And I drink that because my potassium has been a little bit low from the fires. I didn't eat well during the fires, and I ended up in the hospital with having heart issues. And they figured out that my potassium was really screwed up. That's what happens when you're not sleeping at night waiting for fire announcements. And then more importantly, when a fire burns through your neighborhood and almost takes your house. So, the consequences, the stress consequence of those are real. Melissa says, is bladder ease okay? Bladder, the reason why we don't normally talk about bladder ease is because it uses citrus bioflavonoids, which can be a little bit more irritating. So bladder ease is normally not part of the discussion for the typical IC patient. We actually did try to sell it and it just didn't sell. It's not, it doesn't do what we want to try to do. Kiana says, does prolonged stress cause a flare and tightening of your pelvic floor muscles? Yes, absolutely. Because you're in the fight or flight response, hon. When you're in prolonged stress, your body is living in a state of anxiety, in a state of preparing to fight or flee. That changes your blood flow, that changes your muscles, it changes all sorts of things. And long-term prolonged stress is going to have terrible consequences on your nervous system and on your muscles. And so it's really important to, again, have some pretty good stress management skills. Been there myself. The passion for Gatorade, what's interesting is it's not lime, it's not citrus, and it's never bothered my bladder. I dilute it 2 to 1 with water. Kiana says, it feels like a vice in my urethra and pelvic area. CT came back clean, and so I'm assuming stress caused it. And Becky says, physical therapy helped me with that, along with learning to manage my stress and diet. Right. Yeah. So I sent out a newsletter. I worked until 4 in the morning, the night before Thanksgiving. I'm so behind. It's just ridiculous how behind I am because of the fires. I did let people know that the Zoom meeting normally starts around 2. And so I'm going to just go ahead and do it. I don't know how long we'll go today. I'm here if you have questions. If you don't have questions, that's fine. I will go play. Well, I got to write my magazine, but it's Sunday and it would be nice to have a little bit of time off. Like, really? Hold on a sec. Also too, hey, I am going 2 things. It's a holiday season. And for the next 4 weekends, I'm going to send 2 small gift baskets to IC patients. One on Facebook and actually, y'all have to email me. I'm not going to tell you what's going to be in them, but they're going to be a small random group of various IC things. It might be bladder-friendly teas. It might be a Cysto Protect. It might be Preleaf. Our lovely sponsor for this meeting, of course, is Preleaf, produced by DSC Healthcare Solutions. Preleaf is the oldest supplement that's out on the market today. It helps you make some foods more tolerable because it will reduce the acid in the food. So it's a calcium glycerophosphate product, been out for decades. And this has been the product that has helped patients who have bladder wall sensitivity eat a more balanced diet if you're somebody who reacts to a lot of things. So Preleaf is viable. So if you are, and it might be a book, it might be a video, we'll see. So if you are interested in getting a gift basket, I'm just going to pick people randomly. You need to email me, icnetwork@mac.com. I'm going to do it. I'm going to try to do 2 for every meeting, 1 or 2 for every meeting. If you would like a little holiday gift basket. So icnetwork@mac.com. You have to mail me your snail mail address. I need to know what your real physical address is so I can put it in the mail. And then also last weekend, I had a lady, and I don't remember her name, and I haven't watched the video, who had extreme sensitivity. And I was going to send her the echo egg. The echo egg is a chemical-free way of doing your laundry, but I could not find her email for her mailing address. And there were 2 people who emailed me who wanted something, and I didn't get any of those email addresses. I was looking for them. I don't know what happened. Mary Jo says pre-leaf can make the calcium in your blood increase, so be careful. It's good, but yeah, absolutely. You do not eat pre-leaf like candy. You only take it before a meal, 1 or 2 capsules at the most. Patty says, it doesn't help my stress levels, so I get very scared that nothing I try will work and the pain will just get worse and worse. You know, Patty, that's really normal. I mean, I understand that. But the thing is that you're now living in a world of anxiety and you're spinning in place because it's preventing you from doing stuff. And we got to bring that anxiety level down, because seriously, you're not God. You can't predict the future, just like I can't predict your future. For all we know, the next therapy you do or supplement you try will resolve most of your symptoms. And so you have to walk into it hopeful, optimistic, and focused on wanting to get better. If you just let anxiety stop you, you won't do anything, and you could suffer for years, and we don't want that to happen. We want you to get better. But there's a great series, a quote I like: ask, action, satisfaction. You can't get satisfaction until you take action. And you can't take action until you ask the question. So you have to ask the question first. Doctor, what is triggering this pain? And the doctor goes, might be your pelvic floor. So now we're going to take action. So we're going to go to a physical therapist and we're going to get that checked out. And then with physical therapy, the physical therapy could very easily resolve the muscle issue. And there we have satisfaction. Ask, action, satisfaction. Mary Jo said, let's see. John says, and I know it's not John, it's his wife. What are the best forms of magnesium? Some irritate. I don't know. Off the top of my head, I don't know. I've heard that magnesium stearate is kind of bad. I don't remember why. I don't know, hon. Why is my tooth hurting? My front tooth hurts. Not good. I hate dental work. Stop it. It's just a little bit. It's just like a little achy. All right. So here, hold on a sec. Oh, man. I totally forgot to record this. Darn it. Oh, well. Yes, you did hear basket of goodies. So make sure you put your snail mail address in there. I really want to just try to, guys. Oh, and also listen, for those of you on Facebook and YouTube, I'm also participating in a sweet little gift exchange, and anybody's welcome to join. Where basically, and I rarely do stuff like this, and I certainly can't post this on my Facebook page because we've got so many thousands of members. But if you are interested in just doing a sweet little gift exchange with other people, pop me an email, icnetwork@mac.com, and I'll send you the instructions. Because it's, if there was ever a year that people needed a little bit of extra love and a little extra surprise, it's this year. And so if you email me, icnetwork@mac.com, gift exchange, I can send you the instructions on how to do that. You can post it on your Facebook page, and maybe you'll get a bunch of gifts too. But it's just fun and different. And again, I don't do this normally, but I think this year is an exception. I just think we all need a little bit of extra love right now. We need extra love. No doubt about that. I am starting the Zoom meeting. Oh God. You know, starting Zoom is like looking at a you ever make the mistake of turning on your iPad and having it below you and seeing everything here? It's like, oh my God. I look at my face and go, what the hell happened? How did this happen? I'm 25, for God's sake. There's Sarah. I'm going to put the invite in. So anybody who wants to come on over to the Zoom meeting, that would be awesome. Love to have you. This is where you get to ask questions. The Zoom meeting is not, people will not see your face other than other people in the actual Zoom meeting. So that's very cool. Debbie, thank you. Got that message? All right, YouTube. There is your invite to the Zoom meeting, Facebook. Ashley says, some people can be cured if it is really an embedded infection. What are your thoughts? So here, let me put your Zoom meeting invite in here first. All right. So here's the deal. Is that from day one, before Facebook, back when all we had was America Online, CompuServe, and internet news groups, there was a robust community of people who suggested that IC was a result of infection. And those fights, especially in the news group, were vicious. Y'all think Facebook is bad, and believe me, Facebook is bad. The internet news groups were blisteringly, brutally cruel and bad for people who were trying to have a good discussion about the potential role of bacteria. Then we had Dr. Paul Fugazzotto, who became a kind of a bit of a cult figure. He was a PhD who ran a lab in, I think, South Dakota, and he believed that patients had a chronic fastidious infection. And so he asked us to send him urine. We all did that because we didn't know anything about it at that point in time. I did it myself. My mother did it. We all did it. We since learned, like I tested positive for Enterococcus and Micrococcus, but we since learned that his technique was flawed and there were probably a lot of false positives. He was reusing little glass vials that he was sending out, and now we know some bacteria can survive autoclaving. And so the kind of assumption is that his urine collection methods were flawed. I asked, we had a very long, robust online guest lecture series, which we don't do as much anymore right now because I'm doing most of these. And I asked every doctor, every top doctor, including the director of the National Institutes of Health at the time, what are your thoughts on chronic embedded infection and fastidious infection? And nobody had any data to support it. And so that has come and gone and come and gone. Now we have, then we had a nurse practitioner named Ruth Kriz, who followed Dr. Fugazzotto. I had a lovely chat with her a couple of weeks ago. And she made some pretty important strides forward. She was one of the first to find Lyme disease in some patients. So she needs to get her due on what she's learned. And she is now, I think, retired or close to being retired. And I think she said she was going to do some publishing. I would love to see something that she would publish about this. I need to call her again. But then we have the figure Dr. James Malone Lee out of England. And James Malone Lee is basically the doctor who's driving this now, this chronic embedded infection in theory. And one of the flaws with his approach, in my opinion, is that he basically doesn't believe in testing. He said that none of the testing is valid. So he does a microscopic evaluation of urine and I think looks for leukocytes. I think I might be wrong. But so he's been pretty hotly criticized because he doesn't try to identify the bacteria and or identify drug resistance genes. And that just defeats the antibiotic stewardship that virtually every hospital and every doctor is doing right now. Is there's so much overuse of antibiotics that our biome is being destroyed. And so there is extreme reluctance to recommend any long-term antibiotics. Long-term antibiotic therapy is specifically excluded as a treatment for IC in the American Urology Association guidelines. Jennifer says, my urologist said infection lives in the protective lining of the bladder and that patients with IC don't typically have that lining. He said the lining wears away with inflammation, ulceration, and years of infection. I had 20 years of chronic infection and then haven't had one since I was diagnosed. So, Jennifer, the flaw with that is that when you do biopsies of the bladder wall, the only people who have a lining that's deteriorating are patients with Hunner's lesions. The rest of us usually have normal bladder linings. So, I mean, that's his opinion, but it's certainly not a consensus-based opinion. Most in the IC world most of the top researchers and doctors in the IC world do not support that. And again, as I like to say, there are people who say everybody has chronic infection. It's like, well, what about the patient whose IC started hours after falling on their tailbone? That's not infection. Or what about the patients whose IC began after chemotherapy? That's not infection. Or what about the patients who got estrogen atrophy? That's not infection, although they might be more at risk of infection. And so I don't believe in any all or none statements. We cannot do that. We do subtyping now. And that's what's happening in the IC world, is now we understand the variance in the IC patient population. We're doing much better at finding what's working for people and fixing them and getting them better. So we certainly don't want to give everybody antibiotics. That's stupid. And again, we have the MAP Research Network that found fungal infections. And so if you keep giving those patients antibiotics, you're just going to create worse and worse and worse fungal infections. So I take great exception to anybody who says everybody has chronic infection. I do not believe that. And guys, I sat on the U.S. Army IC research panel for a decade. So, I mean, I got to preview all those big studies. Tiffany says she flares with exercise. My body loves it, my bladder. So, honey, the reason why you're flaring with exercise is probably not your bladder. It's probably your pelvic floor. Your pelvic floor muscles. Anytime movement triggers a symptom, we're always going to be looking at the pelvic floor muscles, and what's happening to these muscles and how is that influencing the bladder. My sinuses have been, maybe it's my sinuses. Anybody else have like really weird sinus pain? Like my sinuses, I have been grinding my teeth, right? So like this really hurts right here. Does it hurt right here? Trying to figure out why my front tooth hurts. Maybe, I don't know. All right, so y'all have is IC an autoimmune disease? The answer is no. The only patients who have an autoimmune component to it are patients with Hunner's lesions, and the biopsies prove that. So if you have Hunner's lesions, then yes, there is an autoimmune element to the lesions. But the rest of us, there's no autoimmunity involved. See, look at that. See, I pressed my sinuses, and now I can feel it. All right, guys. Well, let's go ahead and start the Zoom portion of the meeting. We only have 2 people in here. That's fine. If anybody else wants to come in, feel free. I know people are decorating the Christmas trees and doing that. I wasn't even sure I was going to do a meeting today, but it's like, all right, I'm here. Let's do it. All right. So, just so you know, the people on Facebook, people on YouTube, you're going to hear this discussion. But Sarah, they're not going to be able to see you unless, no, they won't be able to see you at all. The only people who can see you are me and whoever's on the iPhone. So Sarah, are you there? Can you unmute yourself? I cannot unmute you. For all we, oh wait, oh, I just accidentally muted you. You unmuted and then, try it again. Unmute yourself. There you go.
Okay.
Hey girl, how are you today?
I'm okay. I have a long history of IC, and I seem to be kind of in remission right now.
Awesome.
I was taking, I think what really helped me was the amitriptyline that was prescribed about like maybe 10 years ago that I was taking. Hydroxyzine helped. But then I had, last year I had a syncope.
You had a what?
And a syncope, it's like when your heart kind of skips a beat and you pass out.
Oh gosh, okay.
So, you know, the whole emergency thing in the hospital. And the cardiologist said that I needed to go off the amitriptyline and the hydroxyzine.
Yeah.
Which I did, of course. And okay, there we go. And
so are you, have your symptoms come back?
I'm still, you know, I have to pee very frequently.
Okay.
But I don't have the pain that I used to have.
Okay. Okay.
And obviously I'm not, you know, unless something changes, and I'm going to follow my cardiologist's recommendations. I take Cystoprotect.
Okay.
And I take that over-the-counter Cranberry probiotic thing, just to make, you know, to keep my bladder healthy and not get infections. And
so I would the cranberry, you got to be really careful with the cranberry. I mean,
I know it doesn't, you know, it's never bothered me. Not this particular brand.
Well, but you have frequency urgency, so something's bothering you.
Really? You think? I'm kind of afraid to go off it. I'm afraid of getting infections again. Do
you have the bottle?
Yeah.
Can you grab the bottle and show it to us? Or show it to me so I can see it?
Yeah.
And I'm going to grab it.
Let's see. I guess that's it there.
Ooh, yeah.
But you know, when I was taking the amitriptyline and hydroxyzine, I've been taking this for years, and it's never bothered me.
Well, yeah, but you're older now, and you have a more compromised bladder, and that does not look good to me. Here it is right here. Aside from the fact that it has titanium dioxide, which of course caused the whole cancer scare with Cystoprotect last year, does it?
Oh, right. Mm-hmm.
I'm just trying to. So, hon, it's got citric acid in it. It's got ascorbic acid and citric acid in it. I would not with a 10-foot pole as an IC patient. I wouldn't. I understand. So this gets into subtyping, right? This gets into subtyping. So if your IC was muscle driven and you had a completely normal bladder, then yeah, you would have been able to tolerate that. But if you had, say, Hunter's lesions or estrogen atrophy, where your bladder wall was absolutely compromised, that cranberry supplement would be a really big mistake. A huge mistake, because the citric acid and the ascorbic acid combined would absolutely scour a wounded bladder wall. So either the amitriptyline and the hydroxyzine mask the symptoms, or your bladder wall is actually quite healthy and your IC symptoms were being driven by something outside of your bladder. Right?
Yeah.
Normally, the deal is as we get older and we lose that mucus, we don't have protective barrier. So we are more vulnerable to infection. It's easier for bacteria to reach those cells and infect those cells. What the research has shown is that PACs, paranthocyanidins, which come from cranberry but are not cranberry juice driven, are the most effective in research studies to prevent infection. And so prevent.
Oh, okay.
Prevent with, or Allura, ELLURA. But what the research shows is that it's the PACs that are the most effective. And so with prevent, delivers 290 milligrams of Oracran, which is 40 milligrams of PACs that are extracted from the American cranberry fruit, but there's no residual acid in this. And there's no...
I can get that in the IC shop?
Yeah.
Okay.
And the vitamins, there is vitamin C in here, but it's not ascorbic acid. It's calcium ascorbate, which is the lesser acidic. And of course, we can go both ways, because some people say the acid is important because your pH changes as you get older. But anyway, this is the one of all of the natural approach nutrition products. This is the one that has most urologists excited, because it's half the price of Allura. Okay. But let's talk about your heart and the amitriptyline. So, as an anticholinergic medication, amitriptyline is well known for triggering heart issues. And in fact, that happened to me.
Really?
Oh, yeah. And it only took 3 months for me to have a problem. So I took it for 3 months. And then what I noticed is that I was throwing a lot of PVCs, and my heart rate was very irregular. And so I had to wear a heart monitor for a month. And it's scary as hell. You know, there's nothing worse than feeling your heart's being weird.
Right.
And what it did to me, normally you've got 2 electrical nodes in your heart. You've got your SA node and your AV node, which is why your heartbeat is beep, 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 beep. It turned a third one on for me. So my heart rate was beep, 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 beep. And if normally 2 of them beat at the same time, so it's like beep, 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 beep. And it's still there. It's not as bad as it was, but I mean, it's been 20 years since I did amitriptyline, 23 years, somewhere in there. And I still have that a little bit of legacy of heart sensitivity. And that's what happened. So when, whoops, hold on. We have some feedback going on here. Okay. So in that time, I have gone through periods where I could do decaf coffee. But what I found is that after about 6 or 9 months, that third node started getting worked up again. It just sensitized all of the nerves again. And that's indeed what happened to me. I was drinking a lot of decaf coffee all through COVID, got a flu shot, and I started throwing same exact thing. And except I didn't pass out. I actually drove myself to the hospital. But the doctor was just like, he looked at my history and he goes, "Are you doing caffeine?" I went, "Decaf." He goes, "You can never do that again. Never. Your heart is too sensitive." So that's a legacy from amitriptyline from 20 years ago. So I think that you made the right decision. I think the doctor I would not touch amitriptyline or any anticholinergics with a 10-foot pole at this point in time. Understand too, the anticholinergic medications, the longer you use them, they're associated with cognitive decline. And so losing both of those will really only help you in the long run with your nervous system and your brain, because those risks are real. But the fact that you're doing supplements is great. because the supplements, again, they have fewer side effects. There's no risk of cognitive decline. There's no risk of blindness with Elmeron and stuff like that. And you said you're doing Cystoprotect?
Yes.
Okay.
Yeah.
So
I found that the other ones, the Cysto Renew and that new one that came out, I find it upsets my stomach a little bit. Like I found,
so
it just wasn't. I just felt like things weren't quite right.
So
but the Cystoprotect is fine.
Yeah. So Cysto Renew has aloe in it. And quite a few people are sensitive to aloe. So that's probably why you reacted to that. And then we've got the new one, Cysto Mend, which matches the Cystoprotect formula, but also has some pumpkin extract in it. And so, if you understand with the supplements, we always go through periods where supplements might not be available. And so I just try to have
happened with the Cystoprotect, and that's why I did some of the other ones because I couldn't get it.
Right. Yeah. So we always try to have options for those moments. But I think I'm impressed. I'm impressed that they nailed your heart issues to the amitriptyline. That's great. Now we can just not overstimulate your nervous system that way. And if you start having pain and discomfort, you can always try Peora, which is known for calming nerve pain, which I've been able to take without any issues. But right now you're just having frequency urgency. So stick on the diet. You check your try to make sure that somebody looks at your skin, and if you're showing some estrogen atrophy, you might want to do something about that, right?
Oh, so you mean, well, I'm doing hormone replacement therapy for my bones because I couldn't tolerate any of the usual, medications that they gave to increase your bone density. So taking 1/2 of the FemHeart, the 1/5 dose. And I've been on it for like 7 years, and I think I'm doing okay on that. And the cardiologist went through all my medications. He said that was fine.
So just make sure you have somebody look at the quality and health of your skin down below. Because
I do actually,
because
and I take the estrogen, the estrase cream.
Perfect.
I do that once a week.
There you go. So you're in good shape, hon.
I'm in good shape because I refused when I was really suffering. I had a lot of pain. I couldn't go anywhere. The urologist wanted to do a cystoscopy, and also suggested Elmeron, and I refused both. I said, I just don't know. I just felt like it would be the wrong thing to do, so I refused it. And that's when my primary care physician put me on amitriptyline, and that was like magic. It just worked. It was amazing.
Well, and method of action. So it helps us understand cause and effect. So what does amitriptyline do? It calms nerves down. So the fact that calming your nervous system down, improve your symptoms, really tells us that your nervous system was probably driving your symptoms. Which might have put you actually into IC subtype 5 central sensitization. Do you have wicked sensitive skin?
No.
Okay. Do you have a wicked sense of smell?
Yes.
Okay. So you can smell things that other people can't smell, and just smells.
Yeah.
Okay. Yeah. So that's a sign. That's a sign of central nervous system sensitivity. Sometimes that's inherited, like it is in my family. Other times it's a result of trauma. And so our goal here is to calm those nerves down. And one of the ways that we can do that is with amitriptyline. So there you go. There you go.
Okay.
And the odds are your bladder's probably in fine shape. There's probably nothing physically wrong with your bladder.
I feel like that my bladder is okay. And I did do every other single test that you can do without being invasive, and everything came up fine.
Right. Well, and I, I don't have a problem with the cystoscopy, just taking a quick look. I mean, if you were bleeding, if your symptoms were not responding to therapy, then yeah, we want somebody to look. But the fact is that you responded beautifully to therapy.
Yeah,
But
and I wasn't bleeding. There was no blood. So
right, but the challenge here is you do have symptoms of frequency urgency, and it would be nice to know why. And answer number one could be that you have a more sensitive nervous system. And the sense of smell demonstrates that, because that's a brain function, and central sensitization is a brain function. Or, number two, maybe you've got a little bit of estrogen atrophy, which is making those nerves a little bit more vulnerable. But then the sister
I'm 72, so
you are not 72. You do not look 72.
That's very sweet of you.
Well, you don't. It's so weird. Getting older is so much weird. How old do you feel inside?
Oh my gosh, it depends. When I'm busy and active and doing stuff that I love, I'm back to being young again. And sometimes at the end of the day, I don't know. I try to keep active, and I have to thank IC for making sure that I eat well, like all natural foods. And it's interesting that I never check all the ingredients in this health supplement, because I stay away from those things. I always stay away from those things, and then I don't know how I think I was just petrified of getting a UTI again, because I've had so many of them.
Well, and so again, what the research shows is that PACs are far more effective than that. But you could be a new woman in 2 weeks once you stop the daily acid irritation.
I will. I absolutely
will. You check back and let us know, okay? All right, hon. Happy holidays to you. And keep in touch.
Okay. Thank you.
All right. And then we have, and again, anybody on Facebook or YouTube, if y'all want to come in, that's fine. If you don't, that's fine too. It's your choice entirely. I'm putting the invite one last time into Facebook. My email is icnetwork@mac.com. icnetwork@Mac, like Macintosh computer. icnetwork@mac.com. And then somebody said they flared horribly at Thanksgiving dinner. Oh, Renee, I'm so sorry. What do you think flared you? All right, I'm going to take our second Zoom person who I do not have a name. It just says iPhone. Hello, iPhone. Whoever you are on your iPhone, can you unmute yourself? Oh, I hear hello there. How are you?
Good. How are you?
I am good. I'm sending you just message if you'd like to start your video. If not, that's okay too. All right. How are you doing today? How is life today?
Good. I'm in Canada.
Okay. Welcome. Have we talked before?
No.
Okay.
No. Well, see, I'm not even sure if I have IC.
Okay. What are your symptoms?
Well, I have, as my bladder fills, it gets painful. And then once I, go to the washroom and relieve my bladder, the pain goes away.
Okay.
But other than that, I don't really, I just in August, I had really bad arthritis in my hip.
Okay.
So that really contributed to a lot of the factors, because, well, I think it did. I don't know. But I do have urgent frequent. I do have, but I don't. I've never had a lot of urinary tract infections or anything like that.
How old are you?
I just turned 60 this year.
So the first thing we're always going to look at, and the good news is you don't have a history of a lot of bladder issues. We're just looking at estrogen atrophy, hon. That's it. Your bladder relies on estrogen, and as you lose estrogen,
I had one of those, the E-rings.
Yeah.
You insert, and it's good for, I think, 3 months.
Okay.
Does that make a difference?
Well, The proof is in the pudding. What does your skin look like, and is it responding? I mean, the nice thing about the E-string is it's not a cream. It's just you guys, it's basically it's like a round rubber zero that's coated with time-release medicine, and you stick it up your vagina and you just leave it in there. And sometimes it falls out and you rinse it off and you stick it back in there. The proof is in what does your skin look like?
My skin doesn't like, I have people told me that, I don't look 60, but I have, I have jowls and,
No, I mean down below. It's down below your skin down there, because what happens is, and then it develops these funky lines in it. And if that's the case, then you might need to be using a different topical estrogen to try to give that skin more. It's hard to say. It's hard to say. But,
okay. I don't have that. No, I don't have that.
Okay.
Down there.
Well, what do you mean you don't have that down there? At your age, your age, you have to have some down there. It's not going to happen.
I have some, but I don't think I'm not sure. I'll check with my doctor.
So remember that your bladder needs estrogen too. Your bladder relies on estrogen also. It also has a thick coating of mucus. And as we age, that thins and the bladder gets more vulnerable. And the fact that you have pain as your bladder fills with urine that is relieved by urination points specifically to your bladder wall. So sometimes what happens is, the good news here is you don't have a history, but you also didn't really understand that your bladder wall is becoming more vulnerable. And so if you were drinking coffee now, you might have been able to get away with coffees in your 40s and 50s, but all of a sudden one day coffee hurts. And that's just
I don't drink coffee.
Or soda, or artificial sugar, or a simple multivitamin like a Symptom or a One-A-Day. Those would be all things which slowly over time your bladder would have a challenge defending itself to as it gets more vulnerable and compromised. Does that make sense?
For sure, yeah.
Yeah.
See, that's like I've read a few books. I got a couple different books on IC just to see, and I seem to have some. I guess the urgency and the pain made me think that I had IC. So,
but today it's not just IC. We have to be more specific. IC doesn't really mean anything other than it's a grab bag diagnosis. We have to try to figure out what's triggering your symptoms. And so it could be estrogen atrophy, or it could be maybe you've developed a disorder walking. Maybe you've got to have a new hip or knee problem, which is creating chronic muscle tension. You need to have a normal workup. You need to have somebody study your urine. Let's just make sure there's nothing funky going on with your urine. They need to do a pelvic floor assessment to see what the health of your muscles are, and they need to look at your skin.
I'm doing that next week. I'm going to see a pelvic floor physiotherapist next week.
Good. So that's going to be very interesting. It's going to be very interesting to see what they find. So I wondered
if that was part of the problem too.
Yeah.
Because I'm always reading about it. I'm always trying to, to find more information for myself. But I just, there's nothing, I haven't had like a lot of urinary tract infections. I don't have a lot of this, like I can eat pretty well, whatever I want. I don't have any issues with food. I haven't noticed that certain foods bother me more than others. I haven't noticed that. So I really didn't know what I had.
Well, it could be anything at this point in time. It could be your bladder wall. If you have pain and discomfort as your bladder fills with urine that is relieved by urination, that points to your bladder wall. But the fact that you can eat certain foods and you're not flaring, that's interesting, because then that says maybe your bladder wall isn't too bad after all. So then we want to look at things outside of that, like your pelvic floor. And so I would even have a gynecological workup. I'd go to your gynecologist and say, hey, I'm having these symptoms. Can you make sure that there's nothing else going on there? you know?
Right.
You know, sometimes what happens as we get older and our periods stop is we get something called complex endometrial hyperplasia. And what that means is that even though we're not having periods, there's still little tiny bits of residual estrogen that is triggering the uterine lining to grow. And so the uterine lining kind of gets thicker, even though you're not having periods. And so, you know, it's way too early, but the good news is you don't have a history. And so that really excludes you from Hunter's lesions, and that excludes you from kind of the more chronic, quote unquote, IC that we see. It really points instead to either muscles or aging. So I think that's what you've got to do next. So let's see what the doctors have to say.
Okay.
And the
so you think I should see about my estrogen?
Well, I think you need to have somebody look at your skin, and the physical therapist can look at your skin too. But, you know, I mean, when they do their examination, they will do an internal examination. And if you're dry, they'll tell you you're dry. And at that point in time, you can then go back to your gynecologist or send them a message and say, hey, can we maybe revisit this? Maybe the E string isn't enough. Okay.
All right.
Guys, I need to take a quick bathroom break. I will be right back. Okay.
Okay. Thanks, Jill. It was nice to talk to you. Nice to meet you.
Nice to meet you too.
Okay. Bye-bye.
All righty. Are you all listening to Christmas music yet? I'm not into it yet. I will be. All right, Bola. Are you guys just YouTube and Facebook? We're doing the National IC Support Group meeting. Right now, we're doing the Zoom portion of the meeting. So you're hearing the discussion, but you're not seeing them. Lisa asked, where do you buy Bladder Builder? Just go over to our website, icnetwork.org, and click on shop. All the supplements are right in the IC network. And the nice thing is when you buy stuff from us, you actually supporting these support group meetings, and we really appreciate that. Bola, the email address, you're half right. ICnetwork at M as in Mary, A as in Apple, C as in Charlie.com. M as in Mary, A as in Apple, C as in Charlie.com. All right, hon. Okay, so you sent me a private message where you wanted to talk about intimacy, do you want to do that online or do you want to do that offline? Would you rather talk about that privately or do you want to do it in the meeting?
You can do it publicly if you want. Thank you.
Sure. Well, hon, what country are you from?
Manchester, England.
Oh, that's right. Okay, sorry.
Okay.
No, I thought I heard a different accent in there. I thought I heard it.
I'm from. Yeah, originally from Nigeria.
Well, there you go. Okay, I thought so. Okay.
Well, yeah.
Yeah. So, do you want to tell me what what you're struggling with? Is it painful? Tell me what's going on.
Yeah, sometimes it can be painful, but the IC pain comes the next day, I think, and I suffer throughout the day after.
Okay.
Sometimes all week I'm on it.
So with intimacy, the reason why there are three fundamental reasons why it can be painful. Number one, if you have tight muscles. So understand that anytime you have pain anywhere, for whether it's your period or whether it is a bladder infection, your muscles are going to get tight to protect you. That's called the guarding response or the guarding reflex. And so, and I call it the chicken versus the egg dilemma. Which comes first, the chicken or the egg? And for us, it's which comes first, the bladder or the pelvic floor. They're both involved. And they're both involved because they're so intricately connected. Our challenge is trying to figure out which is primary, which is secondary. For some people, IC begins after a direct bladder injury like chemotherapy or drinking too much diet soda. And of course, because the bladder wall gets irritated, the muscles get tight to protect you from that pain. But for a lot more people, it all begins not with a bladder injury, but with a muscle injury. That a muscle is hurt, whether it was from having a baby or falling or being abused or being raped or something like that, where there's a muscle trauma. And that because of the muscle trauma, the muscles get tight and they restrict blood flow to the bladder, and eventually the bladder wall gets involved. So every IC patient, whether it's bladder or pelvic floor, will at some point in time notice pain with sex. Usually it's because you have tight muscles. And generally what they will do for that is they will give you a little bit of a muscle relaxant to use afterwards. So, getting into a hot shower, sitting in a warm bath, using a heating pad on your belly, on your lower back. And it usually begins 6 or 8 hours after sex for a woman, and it will last for a few days. It could last for a day or 2 or 3. And those are just, muscles that are just gently spasming as part of helping sperm meet egg. And so if you notice that different positions trigger pain, then that also is going to point to muscles. You got to be willing to try different things. I have a whole section on sex and intimacy with suggestions on that over on our website. You can look at that. The other thing we want to look at is dryness. Are you dry? Because if you're dry down there, then, dry skin on dry skin hurts. Normally.
Yeah, always dry. I'm always dry.
Okay, well, how old are you?
I'm 52.
Oh, girl, you're dry. This is what happens. The dryness normally starts, in your 40s and sometimes earlier if you've had a hysterectomy. And so, dry skin on dry skin is painful. And so, you got to use a lot of lube every time you try to have sex, so we don't injure that skin down there. So, KY is fine. I like KY myself, but don't do any lubes that have scents or that cause a heat effect. You just need a simple, plain KY jelly, a lubricant jelly, or something like that. Okay.
I have, yes. I have, yes. I use it for a while, but it doesn't work anymore. There's a lubricant they call, yes, it's a natural one.
Yeah. And how is it not working anymore? Is it you're not using enough?
I don't know. Oh, okay. I just use the whole tube in there, and doesn't do anything for me.
Well, so again, I think you want to get a doctor to look at your skin. And if you're if you're as dry as I think you are, because you feel dry down there, and you might not even need to see the doctor, you might just be able to email them or make a phone appointment. Using a topical estrogen product would help your skin produce more mucus.
Okay.
And I would Google or search for we call it estrogen atrophy or vaginal atrophy, because that's describing, and I'll type it in. Look at those symptoms, because I bet that's where you are.
Yeah.
But again, I'm not a doctor. I'm not supposed to give you medical advice. I try not to do that. I just try to plant seeds, but these are the most logical seeds for what you're describing.
Oh, thank you.
Okay.
Yeah. You
are very, very welcome, my dear. And it's lovely to talk with you. And I hope that you have a wonderful holiday season, and I hope you'll keep in touch. Okay.
Thank you. I will surely do.
You are very welcome.
Thank you.
All right.
Cheers.
Okay. We're going to go to Yari.
Hi, Jill.
Hello, Yari. How are you?
I'm good. I'm good. Hoping you might be able to help me a little.
All right. What's going on?
So I was recently diagnosed with IC probably a few months ago. I hear you talk a lot about the specific point when things changed. And for me, it was December of last year. I had a UTI that just kind of never went away. And I never used to get UTIs. I had my son 4 years ago, and since he was born, I started getting them like maybe once or twice a year.
Okay.
I have they detected Hunner's lesions in my bladder. Ooh. And I actually died out of a cystoscopy where they I guess they burned them off. So that was about a week ago. So I'm freshly off that. And I guess I'm at a point where I don't know what to do next. I haven't received any sort of direction on what I can do to help myself other than the diet. So I don't know if I can prevent them from coming back, anything that I can do to prevent the Hunner's lesions from coming back, or I just need some.
Well, you got to, you know, hon, what you've got to do next is heal. You know, I mean, you just had lesions burned off, right?
Yeah.
Okay, so you're now in a healing process here. This is about your bladder, and the good news is that they caught it. That's great. You know, that's fabulous that they found them and they burned them off. And for many patients, they never come back. For others, they sometimes come back, because we kind of have mixed data about lesions. There's one school of thought with research supporting it that sometimes the lesions can be a virus in your bladder, a viral infection. Mm-hmm. And for others, it could be a nerve that's just massively, massively irritated. But you've just done the most important thing. You've had your lesion treated. So power to you. And you're in your post-op recovery. And so now what you've got to do is create an environment that will support healing. So you've got to follow the diet to protect your bladder. Your bladder, it's going to take your bladder a few weeks to really calm down and try to calm the nerves down and repair everything down there. Okay. So diet is important for you. Diet's going to be important for you for probably 6 months. Okay. Not the time for you to be doing anything that's just going to wind your nervous system up. So no caffeine, not even decaf coffee, no chocolate, nothing like that. Instead, you want to do things that will be calming and soothing. And so chamomile herbal tea, peppermint herbal tea. We even have, you guys, where is it? Hold on a sec. for whoops. Hold on a sec. Chill. This is a new tea from a company that we really like called Harney and Sons. It's a combination of chamomile, peppermint, and hemp, which is interesting. And the goal, the goal here is to help people sleep a little bit better. I have some this. Okay, so I'm going to be a little weird here, and you guys don't think I'm a nut here, but I think that have you ever had a cold sore?
I have cold sores, yes.
Okay, so
yeah,
me too. I get canker sores all the time. If I bite my lip, I will have a kink. I mean, I've had, oh God, I got to tell you, my ex fought in the Middle East and he came back, and I flew out to see him. He was in Michigan, and when I came back, the roof of my mouth was covered with canker sores. I had 100 of them. They thought it was something. They thought it was something that he picked up in the war. It was crazy, absolutely crazy. Okay, and here, sorry, you guys. I'm trying to adjust my top here. This is what happens when I put my hair up. Hold on. Okay, I don't know why my top's being weird. Okay, well, I'm sorry. I can't make it right. I don't know what's happening here. Okay, but when you got canker sores, you know that lysine is really helpful, right? Yeah. And they have lysine chapsticks that you can use for your lips, and they work, right? And so, and that's what I've done. I mean, because I've had some wicked canker sores for whatever the hell he came back with from the war. So, oral lysine is now often suggested for people who suffer with viral infections. And so, if I were you, I would Google lysine viral infections and look at what some of that data is saying. Okay. And they're even talking about that with COVID to a certain degree, that the last thing you want to give an active viral infection is arginine, because arginine will help a virus replicate. Whereas lysine...
that's interesting, because a lot of those cysto protect, I actually was looking into that cysto renew, and that has, I believe.
Well, that's because we have research that shows that arginine actually helps nerves function better. But we also know from the viral studies that arginine can also potentially help viruses grow. And so I think it would be interesting to talk to your doctor about maybe trying just a little bit of lysine as a preventative. Now, there's absolutely zero data supporting this. Now, what's interesting, the European Society for the Study of IC, if you look at their diagnostic workup for IC, they screen for viral infections. And I emailed them and I said, what do you do when you find a viral infection? They said, we don't know. So obviously, if somebody has Bell's palsy and they've got a virus that's causing the nerve in their cheek to droop, they give them an antiviral. And so we're just now beginning this discussion about antiviral therapies for patients who have virus in their urine. And this is just the beginning state, level for that. You could also have a next generation test to see if they find virus.
Yeah. And I did one. They only did, I guess, the PCR. They never went into the second level testing, which I don't know if that's something that I needed to do.
Yeah.
I didn't think to ask at the time. So the doctor just kind of did what they thought was best. So I don't know if I could benefit from having the second level testing.
If it will screen for viruses, I say why not? Because this could again, when you look at the data shows that when you treat a lesion, the lesions often disappear and never come back. But for some people, they do come back, maybe not as many, but they have been known to recur. And so they just go in and they inject them with a steroid or they cauterize them again. But that whole landscape, treatment landscape, is going to change now if we can support more of this viral information. The U.S. National Institutes of Health Map Research Network just released their viral study, and they also found in a small percentage of patients active viral infections in their bladders. And they found the same virus, the polyoma virus, in IC patients that the Europeans were finding. So, just know that I'm really on this. And as soon as we get information on potential antiviral therapies, I will get it out as quickly as I can, because I think it's really, really important. But in the meantime, we don't know if that's the case for you. And I think having the next level test would be fascinating. I would do it. I would do it.
Okay. Definitely.
I mean, and you and I both have herpes. We both get canker sores. It is what it is. They start in childhood from an old auntie giving us a kiss when we were a baby. 70% of the US population has viruses. And the other virus that has been implicated is Epstein-Barr. So if you ever had mono, so they have found the Epstein-Barr virus, and HPV. We're now starting to find some people who have HPV infections, particularly in their urethra. So, it's a landscape. A virus is the dirty word today, I was thinking about it, I was thinking about it, because normally for something to replicate, there has to be a male and a female, like and normally there's some sort of, coming together that creates new living beings. And viruses are just they're so brutal. Because they replicate all on their own. They just turn our human cells into their own viral factory. And but we've had them for millions of years.
Yeah.
It's just part of the normal human biome. The polyoma BK virus, we all have. It's not a sexually transmitted disease. We all have it. It's a normal part of the human body. It just gets turned on in some people who are a little bit more immune compromised.
So do you think that UTI would have been a trigger point for me to develop this, just because everything changed since I had that one UTI and just never went away. And I went from being completely normal to my life completely upside down.
Well, do you know what kind of infection it was?
It was an E. coli bacteria.
Okay. And how long ago was that again?
That was about a year ago.
Okay.
And then from there, yeah.
So when you did the next generation testing, did it continue to find the E. coli?
Well, no. Actually that test was recently. That was about a month ago, just because my current doctor doesn't do them.
Okay.
So I had to find another urologist to do it, because I was pretty much set. But I had a UTI last December, confirmed with a regular culture E. coli. They gave me antibiotics. Symptoms were still there. I still felt the urgency, the pain, the burning when I went to the restroom. That's the ongoing symptom that I've had.
Did it ever improve?
No, it never improved. And then I had another UTI, and then other, what I would call, I guess, a UTI, but that they were not confirmed with cultures. They were just the symptoms. So it seems like my UTI just never fully disappeared, and I've had ongoing burning when I go to the restroom, as well as issues with intimacy, and that's been since that UTI last December.
Okay, but how old are you?
I'm 40.
And have you had a hysterectomy?
No.
Do you still have your periods?
Yes.
Okay, this is going to be a shot in the dark, but let me just say this. Have you had moments when you're so angry you want to slug somebody and you don't know why?
Well, since this, yes.
Okay. Are you waking up anxious? Like you don't know why you're anxious, you're just anxious?
Yeah, I don't know that I would call that, but I know that I've been under a lot of stress, and I don't know if I can attribute that, and that I guess the stress does make me a little anxious.
So, you're not 20 anymore, you're 40, and you are either in perimenopause or you're coming close to starting perimenopause. And that's when you would think that your ovaries would gradually shut down, but what happens is instead of being gradual, they get very random. So you could have triple estrogen one day and no estrogen the next day. I mean, it's amazing how the ovaries change. And it's those sudden spikes in hormones that drive the typical symptoms of perimenopause, like being really angry for no reason. And that's what happened to me when I was like 43. And so it's like all of a sudden I wanted to slug the next person I saw. And I asked myself why. And I had no answer why I was angry. I was just so angry. I was like, I was having to hold myself back. I really wanted to hit somebody. I never did. But believe me, I wanted to. And that was, my gynecologist calls that the rages. That is one of the first signs of perimenopause. So that's why I asked that question. And then, of course, we end up in the free-floating anxiety where all of a sudden you're just anxious. And again, you don't know why, but you just want to run. And that happened to me at dinner or at lunch one day with my sister and my brother-in-law. It's just like I just had this massive need to run. I didn't, but I wanted to. My heart was racing. And that also was just a hormone spike. So
is there any way to check for that?
I mean, they can do blood tests. They could do an estrogen test, but getting them to look at your skin is important. If your skin is showing any signs of dryness, they should know that. They should look at that. But we can also make a case for a fact that you might have a kind of a drug-resistant infection that hasn't responded to therapy. But the next generation test, did you have a microgen test?
I had a microgen test, yeah. And they did only the PCR level 1, and then that was it.
Hon, given your history, I would go back and want more.
Okay.
I would ask for the next level. Let's see what they find. Because that's all suspicious. I mean, you didn't have any bladder issues before this infection, right?
I mean, I guess I went to the restroom more often than the normal person, but it was never really that bothersome. I never had pain. I never really had any burning when I went to the restroom. That infection, it's been ongoing.
When do you think that started, where you had to pee more? Is that since you were a kid?
I don't know.
Are you a redhead? Are you a redhead?
No, I'm a brunette.
Are you Northern European in descent?
I'm not. No, I'm not. I'm Hispanic, so I can tell you my mother's had similar issues with the burning. So again, I don't know if there's also a genetic component to that.
Well, there can be. I mean, do you have a wicked sense of smell? Can you smell things that other people cannot smell, and do smells drive you crazy?
No, not at all. Like my husband's that way, not me. So.
Interesting.
Yeah.
I mean, genetics are real. But normally the genetics that we see are going to be just extreme sensitivity, that we inherit a more sensitive nervous system. Yeah. So, I think it's, I really think that getting that next level of next generation test would be a really interesting piece of this puzzle. And it would either rule it in or rule it out. If it finds E. coli, then then there you go. If it doesn't find E. coli, then I think we have to look at other potential triggers. And that's going to be estrogen atrophy, dryness. It could be that, again, stress. If you've been under a long period of stress, you're going to be tightening muscles, which is going to restrict blood flow to the bladder, et cetera, et cetera. I would also want to know, make sure that you don't have fibroid tumors or anything like that might be pushing on your bladder. Okay. So I think going to the gynecologist and saying, can you find any other potential cause for this? Getting your muscles checked, and then maybe just having them see if they can find anything else that's slightly off and unusual.
Yeah.
Okay.
Yeah. Okay.
But hon, now listen. Now listen. There's nothing about your symptoms that scare me. I am not scared for you at all. At all. You're not peeing blood. Your pain level, I mean, your symptoms are not particularly intense. And we had some really logical things to rule out here. And so I don't want you to be scared of this at all. At all. There's no reason for you to be scared. We just need to be grounded in facts. We need a few more facts so that we can find the underlying cause of your unique presentation of symptoms. And it could be infection. It could be bacterial infection because you did have the weird E. coli. The fact that you threw some Hunner's lesions tells me that it might be a viral infection, or it could just be a nerve that just got super, super irritated from the infection. It could be related to something with your uterus. And so I would definitely want somebody to look at that and just have it's a checklist. Just start checking things off. And for all we know, 2 months from now, things will be better. Now that listen, for Hunner's lesion patients, the most important thing that you can do is just treat the lesion. You've done that. You've already been through the hardest part. There's nothing harder than what you've already done. Everything else is going to be a piece of cake. So you had your lesions treated. Let's give that tissue some time to calm down. Follow the diet. Be gentle. Be careful. You've done nothing wrong. None of this is your fault in any way, shape, or form. I want you for the next 6 weeks to be as kind to yourself as possible, as sweet to yourself as possible, and just give your body an opportunity to heal physically, mentally, and emotionally from this. Okay?
Okay.
Does that sound...
Sounds great.
I know, hon. I can hear in your voice. You're just like, it's hard. I'm just giving you a big giant hug right now. You can do this. You will do this. This will be solved. We will unravel this puzzle and try to get to the basic pieces of this puzzle here. But again, you've already been through the hardest part. You have the cysto. You had them treated. So you're gold. You're gold.
Awesome.
And now let's just, in a couple of weeks, couple of months, let's just ponder some of these other roles too. And if they find virus, then, for all we know, the lysine might help. So let's just see. Let's do it together, shall we?
Let's do it. I'm on.
Okay. You've got my email address, icnetwork@mac.com. If you need if you want to kind of formalize some questions to ask, reach out to me. You can always call me. And, guys, listen, IC doesn't scare me at all anymore. I have the skills and the confidence to deal with whatever happens to me. IC is not fatal. It is not life-threatening. It is a freaking effing annoyance. And the pain can be devastating. But we're getting so good at figuring out why it happens. And when we know why it happens, we're getting better at finding the right treatments for you. And so you carry hope in your heart. Okay, Yari?
Thank you so much, Jill. I really appreciate it.
You're very welcome. All right. Hopefully we will talk again soon.
Absolutely.
Okay. See you later.
Thank you. Bye-bye.
All right, you guys. I'm going to shut down the Zoom portion of the meeting. Oh, God. I just scared myself again. Ugh. All right, the Zoom portion of the meeting is done. We are now back with Facebook and YouTube. All right, you guys, y'all just heard some interesting discussion there. Any comments, ideas, suggestions, thoughts? Patty says she loves this meeting. Oh, honey, I'm so glad. I know I'm doing my job well if I can give you hope and get you smiling again and giving you some ideas to pursue. When Dr. Christopher Payne created his subtyping system for IC, which is what we use, he said one of the greatest tragedies, and Dr. Burkhoff said this too, is doctors who take away your hope and doctors who say this is incurable. Because that is not true. Depending upon your subtype, there are cures. Pelvic floor physical therapy is stunningly successful at reducing the symptoms of IC. The challenge is a lot of you, because it's bladder symptoms, y'all think it's your bladder. You don't understand that the bladder can be a victim of something else happening in the pelvis. And, you know, understand that your pelvis is a small confined area. Look at this. Is this life size? I know. Okay, where's my hip bone? Okay, there's one hip bone. Wait. Here's my other hip bone. Oh my gosh, it's actually pretty close to life size. Okay, so I want you to look at this. This is where Western medicine fails the IC patient and the pelvic pain patient, because doctors stay in their box. They stay in their specialty, and they don't necessarily look at relationships. And IC is all about, pelvic pain is all about relationships. Okay, so hold on. Let me just put on my vulva here. Okay, my vulva is now on. So, oh dang it. I need my vulva. Get on there. So I want you to look at this. Okay, so look at the small confined area. Now, let's look at all the stuff that fits in this area. So let's put the uterus in here first for a woman. Okay, so look at that. That's already taking a lot of space. You can see how carrying a baby. Whoo. Now we're going to put the bladder in. Easier said than done, because it attaches to the vulva. Get in there. Okay. Now the bladder's in. So now look, you can see that if this patient has a fiber tumor here, that's going to push directly on the bladder, right? Now I got to put the rectum in, which is easier said than done. I can never quite get it right. Get in there. Okay, so look. So now we got the rectum in there. Also going through here, you've got muscles, you've got your pelvic floor muscles, you've got nerves, and you've got blood vessels. So one of the things a lot of patients notice is that when you're constipated, you're hurt. Why? Because when you're constipated, you've got stuff in your stool that's pushing against your bladder, and it's also potentially causing your pelvic floor to spasm. Some of you notice, let's see here, hold on a sec. Some of you might notice that your feet tingle when you need to have a bowel movement. Mine do. Started in my 20s, like laying on my couch, I feel the balls of my feet start to tingle. Like, what the hell is that? It scared me at first until I was like, oh, wait a second. Like 10 minutes later, I needed to have a bowel movement. Why? Because there was something going through my bowel that was pushing against the nerve that eventually went down to my leg. Nothing scary. It's like, okay, I get that now. That happens for some of us. Some people have sciatica, where if you look at the back, so look at this. So these are the last vertebrae, and then you've got your sacrum. And look down here. Here's your tailbone. So some of you, a lot of you, have tailbone injuries, and your poor little tailbone is crooked now. And your tailbone is connected to muscle. And so, of course, if you can look here, you can see that your tailbone is curved. Like, okay, can I do this? Okay, so your tailbone is meant to be curved inwards. But if your tailbone was broken and curved outwards, hello, that's bad. If your tailbone is crooked, instead of being centered, it's like pointing to this side or the other side. That can be the root of all of this for some of you. Tailbone injuries are common and consistent. So Western medicine fails because it doesn't look at relationships. We know that organs can change muscle behavior. That's called a viscerosomatic reflex. If any of these organs are in pain, your muscles are going to get tight to protect you from the pain. But the far more important question is, can muscles change organ behavior? And the answer is yes. If you've got tight muscles, they will absolutely change the way your bladder functions and the way other things function, because tight muscles restrict blood flow and do all sorts of other bad things. And so when you're going through that diagnostic workup, there's a lot of things you got to rule out. And it's important to rule out. The last thing we would want is for you to be on Elmeron for 20 years, never get better, and end up blind because Elmeron can cause blindness. Now we know why Elmeron didn't work for a lot of people, because for a lot of you, it had nothing to do with your bladder. Your bladder looks fine. My bladder is fine. Yet there was no doubt I was an IC patient. I had very severe pain. My fundamental issue was, and continues to be, tight muscles on my left side from a bad SI joint. And so the SI joint is right in here. And it's how the hip bone attaches to your sacrum. And this joint is meant to be super stiff and immobile. It's not supposed to move, but for some of us, it moves. And when it moves, the pelvic floor muscles that have to work extra hard to try to hold it together. And mine is an old tennis injury. I said I was a professional tennis player a little bit when I was in college. Classic tennis injury. Classic. All right, so there we go. Now, again, for anybody who wants to participate in a gift exchange, we're on Facebook. We're doing a sweet little gift exchange. You can email me, icnetwork@mac.com, and I will send you the instructions to that. Melissa says, does a cystoscope without hydro reveal Hunner's lesions? Only if it's a specific type of cystoscope. It's called narrow band imaging. So if that clinic has a narrow band imaging cystoscope, then yes, they will be able to identify Hunner's lesions. Candace says, what were the redhead and wicked sense of smell references? I'm both, and I'm newly diagnosed. Candace, welcome. Welcome to the Redhead Sensitivity School. So in our subtyping system, now listen, we know that there's tremendous diversity in the IC patient population. For some people, IC can be the result of a viral infection like Hunner's lesions, which I just talked about, while for others, it can be triggered by muscle injury. There's tremendous diversity in this patient population. Some patients have frequency, urgency, some have pain. Are they the same? No. For some people, it begins in childhood. For others, it begins after menopause. Both diagnosed with IC. Are they the same? No. For some people have completely normal bladders. Others have Hunner's lesions. Both diagnosed with IC. Are they the same? No, they're not. IC is a grab bag diagnosis. It is what they diagnose you with if they cannot figure out what the hell is causing your symptoms. And it's a tragedy because a lot of people are then told it's an incurable bladder disease, when in fact, for many of us, it has nothing to do with our bladders. Our bladder is a secondary victim of something else going on. So I use a subtyping system that was created by Dr. Christopher Payne. This is what doctors at the top, the elite doctors around the world have been doing for about a decade now, is they're trying to define the variants of IC so that we can give you the right treatment for your specific presentation. So let me get this. So here, hold on a sec. All right. So when Dr. Payne introduced his system, here, hold on, I got to clean a little bit of space because I always trash my office when I do these. So in Europe, there are 16 variants of IC using the European Society for the Study of IC and Bladder Pain Syndrome system. In Canada, they use a system called Input, which has 5 or 6, depending. In Canada, in the United States, we don't have a nationally agreed upon system, but I use a system that was created by the doctor who ran the IC research program at Stanford University for 20 years. And he introduced his, here, I'm just getting it right here, hold on. He introduced his in a really provocative way several years ago because he said we should treat IC patients like cancer patients. And of course, as soon as I read cancer in my brain, I'm going, oh my God, why would you say cancer and scare patients? Because there's no relationship between IC and cancer. There's none at all. But when you read his paper, he said, think about it this way. When somebody is diagnosed with cancer, they don't just say you have cancer and send you out of the doctor's office. They say you got cancer of the left breast that is estrogen dependent type 1, 2, 3. They give you a very, very specific diagnosis so that both you and your doctor know what the viable treatment options are. They would never just send you out with a diagnosis of cancer. That's specific. Like for me, complex endometrial hyperplasia with atypia and a vague architectural complex was my diagnosis before for early uterine cancer. All right. Dr. Payne says that cancer patients have a very clear treatment pathway that IC patients don't have. So how do we give you an intuitive treatment pathway with a more specific diagnosis? We need specificity here. We're no longer saying incurable bladder disease. We need something much, much clearer. So let's go through his system. So first of all, he's in private practice now at vistaurology.com. If you want to go check out what he's doing, he has a nice blog. He's very involved in Africa with repair, with a lot of reparative surgeries. He's a lovely guy. Okay, he just got a big award actually. All right, IC subtype 1 using his system is Hunner's lesions. So everybody in the world in the IC community, urology community agrees this is its own unique, distinct group of patients. Why? Because when we biopsy these patients, we find massive inflammation. Massive inflammation. There is biological war happening in a Hunner's lesion patient. And again, now we have a clue that it might actually be a viral infection. And it's in this group that we also see the bladder wall breaking down. Not in the other groups, just in this group. Okay, and Hunner's lesions are treated with lesion-specific therapy. They don't respond to rescue instills or Elmeron or stuff like that, as well as they respond to just cauterizing the damn thing or injecting it with a steroid to calm the inflammation down. That's group 1. Group 2, using the Payne system, is bladder wall driven. So these are the patients whose symptoms began after some sort of direct bladder wall trauma. Normally you have pain as your bladder fills with urine that is relieved by urination. So the fuller you get, the worse you feel. And as soon as you pee, you feel better. And you're probably diet sensitive. So these are the patients who would be reacting to coffee. There are 3 subsets in this group, and there's probably more, but subset number 1 in this group is going to be estrogen atrophy. Aging matters. Estrogen matters. That your bladder has a thick coating of mucus that normally protects it from whatever's in your urine. Unfortunately, that mucus is estrogen dependent. So when you're young and you have lots of estrogen, you have lots of mucus. When you're older, you have much less estrogen and much less mucus. So that means your bladder's ability to defend itself is now compromised. Okay, and so if your symptoms, like we were just talking, you had no issues before, and then finally at the age of 48 or 50 or 60, you suddenly develop frequency urgency, that's the very first thing we're going to look at is estrogen atrophy. When you give that skin estrogen, it will start to produce mucus again. And generally, again, for this group, because you're never going to have a 20-year-old bladder again, even with estrogen, using something that will give your bladder a little bit of extra coating, a chondroitin-based supplement, or a rescue installation with chondroitin or heparin or Elmeron is going to be viable because that will put a little bit of an extra barrier in there. So that's the Sister Protec and the Cystomend and the bladder builder and stuff like that. The second thing we're going to look at in this group is going to be chemical injury. Generally, the bladder gets injured with some sort of chemical exposure. So did you have chemo? Are you drinking coffee? Are you taking multivitamins? Are you drinking diet soda? You know, again, when you're young, you can get away with that stuff. When you're older, you can't get away with that stuff. Your bladder can't defend itself like it used to be able to defend itself. And so for those patients, we want to stop the irritant. And that's why diet matters. We need you to clean up your diet just in case you're a chemical injury patient. And, you know, some of you just like, I don't want this to rob me of something I enjoy. I want to have my 6-pack of diet soda a day. And you have to understand that your body was never built for that. Our bodies were not built to handle massive levels of acid. And it's going to take a toll eventually. And if you continue to do that, especially once you're menopausal, it's your own damn fault. You have to respect the fact that aging matters. And, your body was designed for life 5,000 years ago. The only acid they had 5,000 years ago was once a year when fruit was in season and it wasn't ripe. If you're washing your bladder in acid every day, it's going to take a toll. Okay. Then the third thing that we would see in this group potentially is chronic infection, chronic fungal infection, or chronic bacterial infection. And that's where next generation urine testing helps. The third subtype in the Payne system is going to be pelvic floor driven, pelvic floor injury. This is by far the biggest subtype. So these are the patients who they look at your bladder, it's normal. And yet you're in the office going, I don't believe you. It's got to be infection. It's not infection. Your bladder is freaking normal. It's something outside of your bladder. It's something outside of this poor little organ down here that is triggering it. And in many cases, it's these damn muscles. It's these muscles. When these muscles get hurt, they get tight. And then they, it's a ripple effect. So pelvic floor pain, yes, you can have frequency, urgency, but there's some subtle differences. So people with muscle injuries, you might not have as much pain as your bladder fills. You tend to have pain after you're done peeing. And your pain might not be centered. Your pain might be to the left of center or to the right of center. Movement might trigger your pain, where walking hurts or sitting hurts. But the hallmark symptom of messed up pelvic floor muscles is you cannot pee right away. You cannot pee right away. You're sitting on the toilet and you're waiting 5, 10, 15, 20, 30 seconds, 40 seconds, whatever, until you can relax enough to start your urine stream. Now, so obviously trauma can happen, having a baby, all that sort of stuff can happen. But again, we're now looking at tailbone injuries. That's becoming very big. And most importantly, also mechanical injuries. Is there, Dr. Weiss in his book, Breaking Through Chronic Pelvic Pain, he talks about those patients who, no matter what they do, they can get the muscles to release and get the trigger points to release, but it comes back a week later. Like, what the hell? Wait, I just did this. We just fixed you. Why is it back? And he introduces the concept of a mechanical injury, that sometimes there is another stressor that is tweaking that muscle. And again, oops, hold on. Again, we have to look at bones. How do you walk? Are you walking normally? Do you have a bad hip? Do you have a bad SI joint? Do you have a bad knee? And if that's the case, then there we go. So for me, it is my SI joint here is flexing, which is then forcing the muscles on the inside to be constantly tight and tender and painful. So mechanical injuries happen, and you might not feel that when you're a kid. But when you're older, wear and tear injuries happen. Or if you something simple as one leg longer than the other. I had one patient I worked with was born with a club foot. She's got a very, very messed up foot, and her walking is terrible, and her pelvic floor is terrible. And so in some cases, this is about improving the way you're walking, getting the right shoes, getting the right insert so that you're walking normally, or doing my favorite shoes, Hoka's. These are Hoka One shoes for anybody who has a foot issue. Hoka's. These shoes are the bomb. Oh my God, they're so good. They are so good to improve your quality walking. And there are many, many different types of Hoka's. I wear the Bondies. So, okay. Therapeutically, for somebody with IC subtype 3 pelvic floor driven, our goal is to restore blood flow. That's our priority. That is our intuitive treatment pathway. We have to restore blood flow. How do we do that? By relaxing the muscles. So they're going to be getting physical therapy and addressing any skeletal abnormalities. Okay. IC subtype 4 is pudendal neuralgia. So think subtype 2 is a bladder wall injury. Subtype 3 is a muscle injury. Subtype 4 is a nerve injury, pudendal neuralgia. So these are the patients whose symptoms are positional. They're fine when they stand, but when they sit down, it hurts, or they have sciatica, they have shooting pain down their leg, or they have a buzzing sensation, like sitting on a cell phone on vibrate. It's an electrical pain, it's a burning pain, it's a buzzing pain. That means that or you might have persistent genital arousal disorder where you feel this slight, incredibly awful, painful arousal sensation that you don't want to tell anybody because you don't want anybody to think that you're enjoying this. That actually is a compressed pudendal nerve, the same nerve that innervates the clitoris. All right. So therapeutically for this group, number one, we got to find out which nerve it is and where it's being entrapped. Like mine is entrapped. It's a little tiny branch of the pudendal nerve. It's about 1.5 inches to the left of my tailbone. It's a little tiny branch of the nerve that curves backwards. And that's where mine is entrapped on my left side. And that's why I get a vibration when I sit too long, although it's not doing it yet, which is good. Usually it's doing it by this time of the meeting. So therapeutically, we want to find the nerve, then we want to calm the nerve down. And so that's when using amitriptyline or Neurontin to chemically calm the nerve down is reasonable. Even neuromodulation would be helpful here to calm this hyper nerve down. But also we got to relax the muscles because normally it's a tight muscle that's squeezing the nerve in the first place. Okay, so nerve calming therapies combined with muscle therapies for this group. And then our last subtype is, I think, the most intriguing subtype. It's called central sensitization or chronic overlapping pain conditions. So in this group of patients, it's characterized by having very sensitive skin. We have a wicked sense of smell. We can smell things that other people can't smell, and smells drive us crazy. We can taste things. My sister is an award-winning winemaker. She wins massive awards. Why? Because when you have a more sensitive nervous system, you just taste more and you smell more. I mean, we're the ones who are going to fight the fires. But if you go back 5,000 years ago, there was always needed to be somebody in the tribe who could smell good water versus bad water. That's a central sensitization patient. It is an evolutionary priority. And for many of us, it's genetic. And what we see it more are patients who are red. We see it a lot in redheads and people of Northern European descent. So German, English, Norwegian, Swedish, Scandinavian, in that area. And we can make a good argument that the sensitivity was required because of where our heritage was from. They think about Norway. I'm from Northern Norway. There were, world's blandest diet. Where were they eating? Fish, deer, berries, maybe apples? That's it. Fat. They were eating fat from seals and from whales. That was it. There was no chocolate in Northern Norway. 1,000 years ago, there was no tea, there was no caffeine, which would explain why my body reacts so severely to those. I can't eat chocolate. I will be sick for days. And so central sensitization is essentially a nervous system which is easier to turn on. And we see it systemically. So I have sensitive skin, I have a sensitive stomach, I have a sensitive bladder, I have a sensitive bowel, I have a wicked sense of smell, et cetera, et cetera. Not a disease. Not a disease. It's the gift of my ancestry. And part of the challenge here is that for people, especially redheads who've grown up this way, you're already adapting. Our goal on a daily basis is to calm and soothe our nervous system. We're not going to have scented candles in our home. We're not going to be using smelly oven cleaner. We're not going to be using turpentine. We're very chemically sensitive. So on a daily basis, we have to live in a fairly cleaner environment in terms of chemicals. We can't get away with a lot of chemicals. What was the last thing that got me? Oh, my dad cleaned part of the oven with Windex. Are you kidding me? And I turned the oven on and it was hot Windex. And it took me 24 hours of washing down the oven door and the oven to get the Windex smell going away. And they can't smell it, but I can smell it, and it drives me batty. The other time central sensitization happens is after injury. After injury, that we know that, let's say that you fell and broke your knee. So the bone is broken, and we know that the muscles are traumatized, however it happened. But what about the nerves? What about the nerves? So the nerves get injured when you have an injury like that? And the answer is yes. An injured nerve becomes a nerve that is easier to turn on. And so think about those old timers who they start rubbing their knee when a storm's coming in. They go, oh, storm's coming in. Why? Because the nerves in their knee are more sensitive. And so central sensitization happens after injury. Now, I want to talk for a moment about chronic overlapping pain conditions. I attended in October a 3-weekend virtual meeting from the International Pelvic Pain Society, and it blew my freaking mind. We know that there's a subset of patients who have central sensitization, and we have other pain conditions. So we got the sensitive bladder, we got IBS, we got the sensitive bowel, we got the sensitive vulva, vulvodynia, you name it, sensitive rectum, whatever, sensitive stomach, all that sort of stuff. And the question is, why does that happen? So I had frequency urgency in 7th grade. I had vulvodynia in high school. I had IBS in my 20s. I got migraines in my 20s, chemical sensitivity in my 20s. I didn't have bladder pain until my 30s. And in my 20s, I have to say, I was profoundly depressed because my friends were out getting married and having babies. And I was sitting on the toilet with agonizing bowel spasms for years, for like 3 years, every morning, 11 o'clock. Oh my God. And I was incredibly anxious. My anxiety was off of the roof. I was catastrophizing like nobody's business. I didn't understand what was going on with me. I felt like I was a failure. I felt like I was damaged goods, completely unlovable and unworthy. I did not understand what the hell was happening with my body, and it had been happening for some time. It's one of the reasons why I went into pharmacology, is try to understand my body. What the research with chronic overlapping pain conditions is continuing to find is central sensitization. That we have a nervous system that has been traumatized in some way. And a traumatized nervous system is a maladaptive nervous system. What that means is that normal stimuli that should not provoke pain triggers pain. So you take somebody with a normal bladder and you put 1,000 cc's of water in that, they can walk around for a couple hours. It's no biggie for them. You put 100 cc's of fluid in my bladder and I have to pee. My bladder's healthy. My nervous system is more sensitive. So what we're finding with chronic overlapping pain conditions is that, and the most interesting class I took was pediatric risk factors. Because I had my first issue in 7th and 8th grade. I had my first IBS attack when I made oatmeal cookies too. I remember that. What are the risk factors? And what that found, oh, and by the way, people with chronic overlapping pain conditions, the central nervous system is behaving differently. It's more sensitive. And if you've ever watched a thunderstorm from an airplane, which is beautiful, you see that this cloud lights up and this cloud lights up and this cloud lights up, all sorts of things light up. And that's how our brain functions anyway. Different portions of your brain light up. But when you've got chronic overlapping pain conditions, specific portions of the brain light up. And sometimes they get bigger. And then how the brain communicates to each other also changes. So different portions of the brain communicate differently. There's a network called the salience network. I'm trying to write an article on it right now for my magazine. They discovered the salience network in the brain in 2006. And it is the portion of the brain that motivates you to do stuff. And they were doing brain stimulation with patients with epilepsy. And they found when they triggered portions of the salience network that the patient actually was like raring to go, like, man, I'm ready, let's do this. That the salience network is involved in motivation. And that when that is stimulated, you are ready to fight the fight. And when the salience network is dysfunctional, you're not motivated. You don't want to do it. It's hard for you to do anything. So, God, there's just all sorts of really interesting things happening with chronic overlapping pain conditions. But in essence, it's about retraining a dysfunctional nervous system. Nobody is saying this is a mental illness in any way, shape, or form. No, it's not at all. This is about a nervous system that has been traumatized. And because of the trauma, it's changed how it's operating. And what they found in the pediatric studies is that within the year before it began, there was a trauma, like a broken leg. And it was that original trauma that caused this nervous system to become more sensitive. So therapeutically, for this group of patients, this is about retraining your nervous system to function normally. So you could do bladder therapies for years, and this would not fix this. What fixes this is really mind-body medicine. We have to retrain the nerves how to respond to stress. We have to retrain the nerves how to respond and function normally. And there's amazing research from Harvard Medical School that shows how good this is. That mind-body medicine, progressive relaxation, retrains your nervous system. It calms it down. And on our website, icnetwork.org, I've got an area under self-help of free guided imagery downloads that were created by the Top IC Research Center, proven in research to reduce pain. So if you're somebody who have chronic overlapping pain conditions, you should be doing guided relaxation every day. Mindfulness, meditation, where you're taking charge of your nervous system. You're taking it back. You're not letting it fly off the hop. You're taking it back. You're taking control. You're teaching it how to function normally again. One of the things that we see in this group is uncontrolled anxiety. And what did I say? What did I say? That in my 20s, I developed anxiety disorder like mad. Massive catastrophizing. The world is ending. Nothing will work. No one will love me. I will never have a family. I will be alone. I will be sick. Whatever. And that is a classic sign of chronic overlapping pain conditions, central sensitization. It's about nerves that are not functioning normally, and you are more anxious because of it. And so one of the absolute hallmarks of any good chronic pain program is getting control of anxiety. Because when you have pain that is accompanied by anxiety, your brain will intensify that pain. It will magnify the pain. But if pain is accompanied by laughter, your brain will minimize that pain. So this is kind of one of those chicken versus the egg dilemmas where we don't, why does the anxiety happen in the first place? Is it just because the nervous system is more sensitive or whatever? The sequence of events is still kind of unclear. But this is what we absolutely do know, is that anxiety is real. And I was spinning. I couldn't do anything. I was stuck. Every thought in my brain was negative, along with the migraines and the IBS and everything else. And so I asked myself, now remember, I had a doctor say to me, you will forever be in pain. You will ever live for severe pain. This is your life. Get used to it. And I don't live with pain every day anymore. And I haven't for 15 years. He was wrong. Even though I've been diagnosed with my vulvodynia is done, I rarely have IBS. My bladder is doing perfectly fine. The only sign for me that I still have a lot of central sensitization is my skin is remarkably sensitive and this sense of smell. But I asked myself, why am I better? Why am I better? Because, I'm so much better than I was. And I really honestly think it began with that anxiety management class. Well, it began first with the research that talked about sensitivity. And we had our first research from the University of Maryland, which showed that this ran in families. And when that happened, it was like, oh, wait a second. You mean it's not my fault? Like this runs in my family for generations? Wait, it's not my fault? That was huge. That took a giant burden off my shoulders, right? I stopped thinking that I was damaged goods. It's like, okay, there's an explanation for this. But I still had massive catastrophizing. I mean, it really limited my life. I mean, I didn't travel. I didn't do anything. I mean, I still have friends I haven't seen from high school that live, 5 hours away. I still haven't driven down to see them because the car ride still creates some anxiety for me. But I finally saw how bad it was when I was having panic attacks, just going for regular doctor's appointments. And it's like, I'm done. I do not want to live this way. I do not want to be crying my eyes out an hour before an appointment, panicking. And I signed up for an anxiety management class. And that class completely changed my life because it taught me how to control anxiety. And believe me, I really need it now, going through fires, my house almost burning down, and COVID, and caring for 2 people that will probably not be here 5 years from now. And so my life is filled with stressful situations, but I know how to handle it. I don't let my nervous system get out of control anymore. I don't. When I have a negative thought, I stop what I'm doing, I visualize a stop sign, take a nice, slow, deep breath in for 3, out for 3. And that oxygen turns off the adrenaline from that negative thought. The goal here is to calm the adrenaline response, to calm the fight or flight response. So stop sign, deep breath, and then minimize the thought. And what I say to myself is, oh my God, Jill. So I do that when I'm going to the store sometimes. Should I go to the store? Will I be exposed to COVID? And it's like, okay, stop sign, deep breath. Jill, you're not God. You can't predict the future, and you need to get food and medicine. You can do this. Thoughts have no power. They're just a thought that's being magnified by a heightened adrenaline response that's driving anxiety. So with this chronic overlapping pain conditions, to really sum this up, there's no shame, there's no blame in any way, shape, or form. Yes, you've got IC, IBS, vulvodynia, prostatitis, prostatodynia, rectal pain, sensitive skin, all that's TMJ, lots of TMJ, even painful eyes. That's all part of chronic overlapping pain conditions. The Chronic Pain Research Alliance is stunning. They're so good. It is amazing, the research that we've learned about this. You can Google Chronic Pain Research Alliance. That effort is led by the TMJ Association. Why is TMJ accompanied bladder pain? Now we know why. It's part of the chronic overlapping pain conditions. And ultimately, in the end, this is about skill building, that your nervous system has been traumatized, or you inherited a more sensitive nervous system. Now we've got to retrain those nerves to act normally. We've got to give them normal processes. And this is about you taking control and you doing the things that we know will calm those nerves. And that means some guided relaxation, eating well, exercising, getting outside, creating the good foundation for good nervous system behavior. And then, challenging yourself, doing puzzles, reading books, things that help your brain function, playing music. If you play guitar or piano, if you sing, those are all things that will really help your nervous system calm and be more normal. What's not normal is for you to sit in a room watching Facebook, reading through negative post after negative post after negative post, scaring the shit out of you. You can't do that. You stop it. Stop it. Open the drapes, open the door, get outside, take a walk, breathe in good air. Read a book. Watch a documentary. You got to get the noggin working again. We got to start restoring good brain function. So it's very exciting. I think I'm thrilled with what I'm seeing here. Most of all because it's taking the blame away from all of us. Now we get it. And we're getting better therapies every single day. All right, seriously, can I talk? Sorry, I can talk. Let me get off my soapbox here and go back to your questions. So Candace, that's the whole redhead thing. John Lee, I needed to hear the topics you discussed today. Thank you so much, Loretta. Boria, great meeting. Thank you, Boria. You guys, if you love this meeting, please come on over to the website, icnetwork.org, and become a member and get our magazine. We have a great magazine. This was our summer issue. My fall issue is delayed by fires. But our magazine is where I do our really in-depth stories. The current magazine I'm working on is going to be devoted to the International Pelvic Pain Society meeting. And I have a wonderful, wonderful, wonderful patient story from my friend Chris, who has IC and autism. And God, he's just awesome. All right. Ramona says, I was diagnosed by potassium sensitivity test. Well, Ramona, we threw out the potassium sensitivity test years ago. It's not used to make any sort of diagnosis at all because it causes a lot of false positives. When you put a potassium solution in a healthy bladder, it's going to hurt that bladder. So the original theory behind the potassium sensitivity test was if you put salt on a wound, it would hurt. And it's a potassium salt. And so when Dr. Parsons created that, it was just all about trying to prove that the bladder lining was damaged. But we know potassium is too strong, and it will cause a reaction in healthy bladders. Another option they could do instead is something called an anesthetic challenge, where instead of putting something irritating in your bladder, they actually can put a numbing agent in your bladder like a lidocaine. And if the lidocaine turns your pain off, that also is a de facto diagnosis that your bladder wall is involved in your symptoms. CSB says, can you please tell me the proper name for the pelvic floor wand? Well, the brand name is Easy Magic. And the wand itself, the brand name is IC Relief. I'm sorry. And this wand is the Easy Magic wand, and we sell them in our store. Just go over to IC Network and you can see them. There's a straight one, there's this curved one, and then there's a longer curved one. The curved ones I think are really better than the straight ones. It's not a Thera wand. And you guys, there's a difference between using plastic and glass. Glass is much better. You don't want to leave plastic in your you know what. Anytime you use a plastic wand, you're going to leave a plastic residue. Where the glass wand, it doesn't break. It's Pyrex. It's fine. Super easy to clean, etc. Looks like some people had flares from cranberry sauce. Lisa says, is it possible to be more than one subtype? Absolutely. I am IC. My primary subtype is central sensitization and pelvic floor. And when I was having bladder symptoms, I would have put bladder in there too. LJ says, my sense of smell is so strong. I hate it when I'm nauseous because the smell bothers me. Me too. Me too. And that's just a sign that your nervous system is being triggered more intensely than somebody else. David says, can you do a wine giveaway? I know some people can't tolerate alcohol, and I don't mean to be insensitive, but I'm curious about your sister's wine. You guys, my sister's wine is estate1856.com. So ESTATE 1856.com. You're not legally allowed to do wine giveaways. And I help with the marketing of the wine. And so, no, I cannot do a wine giveaway. They're doing a 30% or 33% sale through December 6th, though. So you could go over there and get it. The Petit Verdot and the Malbec are just to die for. The Petit Verdot, I think both of those won Best in Class, and one at the San Francisco International Wine Competition and one at the LA International Wine Competition. So those are my favorite, the Petit Verdots and the Malbecs. And again, guys, I don't drink a lot of alcohol. Although I will, I have no shame. I'll talk about anything. I will tell you that I did get drunk during the first debate. I hadn't been drunk in 30 years since college. I didn't even know I was drinking wine. I just had a glass. I was like, and she was refilling my glass. The first time the room spun in 30 years. And I felt very guilty because I realized if there was a fire, I wouldn't be able to drive us away. So, yeah. Ramona says, my health history sounds like yours. Many chronic conditions since childhood. Right. You know, the whole redhead thing is interesting. I mean, redheads are their own unique group, and they're slowly going away. It's a double recessive gene, and we're just learning. Redheads have far more nerves. It's much harder for us to get anesthesia, especially in our mouth for dental work. I have way more nerves in my mouth than normal, and so having dental work sucks. Lots of shots, and which is why I usually do sedation dentistry. Donna says, for me, when same was happening, best thing was to drink a lot of water, pee frequently, lay on the couch, hot water bottle, and most importantly, no chocolate and no tea. Now, 40 years later, I just finished off my supper with a cup of tea and 4 chocolates. Donna, oh, the question is, can you get away with it? So you say after stopping work, you began to improve. It wasn't just the work stress, getting up and out early in the morning, driving over slippery roads, hurrying home to get housework. I took Elmeron for years and it helped immensely. So, Donna, I hope you know about the new research with Elmeron and the eye issues. You need to have your retinas checked just to make sure you're not showing any signs of retinal changes from your Elmeron work. The fact that it helped you is interesting because that points us to IC subtype 2 bladder while driven. So then we're going to be looking at chemical irritation. Were you one of those 20-year-olds who just drank a massive amount of diet soda? It happened. Ramona says, I'm having trouble finding doctors to treat me. They say my case is too complex. I'm so anxious now to try to find doctors. So Ramona, that's when you really need to go to a specialist. So there are a handful of IC specialists and pelvic pain specialists in the country. Where do you live, hon? David says, our magazine is a great magazine. Thank you. I know, I was cogitating. I was trying to write my feature article yesterday and my brain kept turning off because it's still stewing up here. Patty says, my husband just said he doesn't blame you for getting drunk during that. I was stunned. I did. You guys, I did. I hadn't been drunk since college. I was just sitting there just stunned. And I was just, I didn't even know how much I was drinking. And in the end, I drank 3 glasses of wine. Woo, and it hit me hard. When I drink, normally I will only drink like a quarter glass of wine or hard cider. I would never drink that much wine, ever. And my neighbor gave me as I found their lost dog, they gave me a big bottle of whiskey with the red thing. What's that big famous whiskey company? It's like, what am I going to do with that? I don't drink that. Okay, so Ramona in Orlando, not a lot of resources in Florida. Come to our website and check out. But where I really want you to go is a website called Pelvic Guru. Pelvicguru.com is a list of pelvic pain practitioners that you can search by database. Or it might be pelvicguru.org, one of those. Yeah, that's it. Pelvicguru.com, and that will give you a better idea of who's doing what in the area. You can also go to the International Pelvic Pain Society, pelvicpain.org, and they have a searchable database on their website too that will also include doctors. Okay, so pelvicguru.com, pelvicpain.org. Donna says, when I was in my early 20s, I drank a massive amount of diet soda, tab. However, I've had IC since the ages of 11. So Donna, I think that we can make the case for the fact that you either inherited some central sensitization, or you suffered a traumatic injury, and it could have been that could have created that central sensitization, bladder sensitivity. That's what the research found, was that for kids, there was usually a trauma. And before my frequency urgency happened, I absolutely fell and broke off the tip of my tailbone. I remember that because I could move my tailbone around with my finger, the tip of it, for months and months afterwards. Hey, you guys, I need to another quick bio, okay? So if you have any more questions, feel free. We've been going for 3.5 hours. I'm willing to take a few more questions. And also, please remember that I will be giving 2 people IC gift packs every week through the holidays. And all you need to do is send me an email, icnetwork@mac.com. I'm going to be picking people randomly. And I'm looking forward to doing that because I think we all deserve just a little bit of extra something. And also, too, for anybody on Facebook, we're doing a little gift giveaway. And I normally don't do stuff like that, but it came from my best friend. It came from her college roommate. And honestly, with everything we're going through this year, I think doing a little bit of something extra to give people random little gifts, nothing expensive, underneath $10 or $20 would be very, very cool. So if you are interested in participating in the Facebook giveaway, also please send me an email, icnetwork@mac.com, and I will send you the instructions for that. Okay, I need a quick bio. I'll be right back. Alrighty then. My throat gets really dry and sore, and then 8 hours thinking I have COVID every single weekend. And for people asking about the Gatorade I drink, it's this one. It's passion fruit. And I can get away with this. It's nothing like a cardiologist put the fear of God in you. Jill, are you drinking enough? Your potassium is down. All right. All right, come on, guys. Hit me up. Give me a hard question. Anybody got any hard questions? Let me go down here to YouTube. Hello, Nicole. You guys are too easy on me. Come on, give me something rough. All right. So let's talk turkey about the holiday season. Tell you what, here's the deal. Here is the deal. The holidays are hard. Anyway, before COVID, the holidays were hard. God forbid you're alone. It's even doubly hard. This is hard. What we're going through right now, we are being tested as a country and as a world like we have never been tested before, but we are being tested individually too. And none of this is your fault. I don't like carrying any shame or blame for anything that's going on unless you're not wearing a mask. If you're not wearing a mask, you're an idiot. I'm sorry, I'm going to be blunt. You're an idiot. I get all of the medical alerts, and this virus is challenging. And not only is it a respiratory virus, it is a circulatory system virus. It attacks your circulatory system. We haven't had a virus who's done that before. And so what I want you to do we all have to just burrow into our comfort zone this holiday season. No expectations, no shame, no blame. If you're going to be, you need to be alone. You need to be in your family group. Please do not travel. Get back, like if you could see my home, I have every decoration I have is up. Everything. My home is over the top. That is how I am getting into the Christmas spirit. We're going to be doing Zoom. I'll be talking to I don't have a lot of close friends. I mean, I have a ton of IC friends, but we all live our lives, so I've got a couple of really close friends that I can cry to over the phone. I'm going to be talking to them. We're all going to be supporting each other. I just want you to put the down blanket on your bed. I want you to find your favorite books. I want you to listen to your favorite music. Music is wonderful for your brain. It restores good brain function. And you're going to think I'm a nut at 60 years old. I am 60 years old. How the hell did that happen? You know who my favorite group is right now? By far, I love BTS from Korea. I love them. Oh my God, their albums are so good and so happy. So turn on your happy music. And just know that we are going to get through this one day at a time. It's okay. You can do this one day at a time. And practice your good self-help. Treat your body kindly. Eat as well as you possibly can. Ask for help if you need it. If you're having a flare, please come to our website. Please, if you can download our flare management guide by signing up for our newsletter. Any of our members, it's on your member page. I want to be here for you if I can be here for you. But so if you need to send me an email, you can send me an email, icnetwork@mac.com. I will do my best. And listen, we're going to get through this, but the next couple of weeks are going to definitely challenge us. Donna says, your lights are glowing in the back. Yeah, I've got these lights. Oh, I didn't turn my love on. Yeah, just light it up. Just light it up. And if you've lost your job, and things are tight, it's okay. It's not okay. It's terrible. And let's just hope that our Congress gets their acts together and actually does something for everybody, because this is hard. But we're going to do it, and we're going to do it together. Candace says, and I'm sorry, I didn't quite say that as I hoped I would say that. I was kind of rambling there. Yes, Maria, comments are on. I can see your comment. Candace says, I need to know about installations. Are there prerequisites before my doctor offers this? Maybe that I'm too new, diagnosed 2.5 months ago, but symptoms much longer. So again, Candace, it depends upon your subtype. Installations are fairly meaningless for Hunner's lesions, for IC subtype 1, IC subtype 3, pelvic floor, IC subtype 4, pudendal neuralgia. There's no role for lesions there. If you've got bladder wall-driven symptoms, then a lesion can help numb your bladder. and calm those nerves down. And so that would be viable. Or if you have central sensitization and the nerves in your bladder are just more sensitive, then you can do rescue installations. The only bladder installations that are really done right now are rescue installations. They're heparin and lidocaine installations or Elmeron and lidocaine installations. We're just not doing DMSO hardly at all. We would never do silver nitrate or chlorpactin. They're not even mentioned in the guidelines. You know, years ago, they thought that if you strip the bladder off, a new healthy bladder would grow if you strip the bladder wall. Now we know that that you wouldn't strip a wound to make it bigger, that's actually a huge mistake. We don't want to do that. We don't want to strip the bladder. So you should never, ever let somebody put silver nitrate or chlorpactin in your bladder as a therapy for quote unquote IC. That hasn't been done in decades. And yet there's still people who are doing it. And again, the DMSO is just not popular anymore. The rescue installations are popular. They're called a rescue for a reason, because they will rescue you out of a flare, because you should normally walk out of the doctor's office with a numb bladder wall. And that feels damn good. Candace says she's IC subtype 5. So again, you know, a rescue installation, heparin lidocaine, that might calm the nerves would be reasonable. But the thing I didn't say, really for IC subtype 5, what you want to look for is things that contain supplements that contain palmitoethanolamide, PEA. So we had a major research study presented last year from Europe. PEA has been used in Europe for decades for chronic pain. It's many, many research studies. I will type it out in chat so you can Google it. So here, hold on, let me just do that. Palmitoyl-ethanolamide. And that is PEA. So PEA has been studied in Europe with fibromyalgia, with sciatica, burning mouth syndrome, all sorts of studies. And I've known about it for, gosh, 15 years or longer. We had some pharmacists here in the United States who were bringing PEA into the United States for IC patients. The problem was it was just too expensive. They just couldn't afford it. And so, you know, we just couldn't talk about it. It just really wasn't that much of a thing. And then last year, researchers from Italy did release the data from their first PEA interstitial cystitis study, and it was stunningly good. That it was a combination of PEA and resveratrol. There was nothing in it for the bladder. It was just PEA resveratrol. At 3 months, 87% of the patients had a significant reduction in their pain. At 6 months, I think 25% were pain-free, and the rest were doing dramatically better. And that was at the Chicago meeting. I was not at that meeting. I was told secondhand that the urologists were just thrilled, because they don't want to give you opiate pain medication anymore. So the thought of having something that could reduce pain was very, very exciting. Now, that formula from Europe is not available in the United States. So Natural Approach Nutrition, I gave them the study, and they created kind of an American version of that formula. So this is PEA and resveratrol. It's called Piora. Now, I gave you the name, the chemical name. And what you want to do is you go to the National Library of Medicine, pubmed.gov, and type that in there, cut and paste it in there, and you can look at all the research studies yourself. Number one, it was extremely well tolerated, and I went through about 30 studies, and only one study had side effects. The IC study showed no side effects at all. But the general consensus was the PEA was remarkably successful at reducing nerve pain, neuropathic pain. And so if you struggle with chronic overlapping pain conditions or super sensitive skin like I do, this would be a very, very interesting experiment. It's called Piora. And people ask me what I take, and this is what I take. And I don't take it every day. I just take it when I'm starting to feel like it pricks from my skin. I'm starting to feel my nerves getting more sensitive. Bladder Builder combines chondroitin and quercetin. Sorry, my light's reflecting there, with PEA and collagen and some probiotics. So Bladder Builder is kind of the most robust and I think the best overall supplement on the market today. So this one would not only potentially give your bladder a little bit of an extra coating effect, it would also potentially might give you a little bit of a pain reduction effect from the PEA. We just did our 1-year follow-up study with Bladder Builder this summer. 60%, and you can see that data on our website. I did a blog on it, icnetwork.org. 60% of the patients who tried Bladder Builder are still using it today. 40% stopped, and they stopped because it was too expensive, or the doctor wanted them to do something else, or they had a side effect, because any of these supplements, then chondroitin-based supplements are kind of known for causing a little bit of gut distress, which is why you always start slow, 1 capsule. Don't take a full dose the first day. Bladder Builder, you always take with food. You never take it on an empty stomach. So in our 1-year follow-up study, of the 60% of patients who were still taking it, 25, I think it was 25%, might have been 22%, were now pain-free using Bladder Builder. The rest had shorter flares, fewer flares, and less painful flares. And so this did exactly what we were hoping it would do, and that is protect the bladder, but also provide a bit of a pain reduction effect. And then the newest one is this one, Allopath, the newest PEA supplement. So this combines aloe. Sorry, I'm trying to do it where the light doesn't shine on it. This combines a soothing effect of aloe with the pain-fighting effect of PEA. And so if you're somebody you find aloe particularly helpful, this might be an interesting one to try. We have discontinued Desert Harvest Aloe in our store because I'm much more excited about this product. That it has 2 methods of action: the calming and soothing effect of the aloe combined potentially with the pain-reducing effect of the PEA. So the PEA is really what most people are pretty excited about. So Maria says, your problem started 3 days after getting implants. Have you heard of similar cases where implants activated IC? And the answer is yes. Not a lot. It's certainly come up before. And I mean, there are several potential mechanisms of action. Concept number 1 is that it's a very stressful event, and anytime you have surgery is a very stressful event. So could you be having stress-induced bladder wall sensitivity? That's a possibility. Number 2, if you're in a lot of pain, we know that your muscles are going to get tight, so it could cause your pelvic floor to get tight. You could be having a reaction to a chemical that they used. Sometimes patients react to anesthesia or maybe an antibiotic. They're kind of known for using a lot of antibiotics to prevent infections when you have breast implants. And I think the question too is, would a silicone implant itself, could you be having a reaction to the pouch? Could you be having some sort of, what do they call it? The implant bag? I mean, that is not a normal human grade. I mean, it's a human grade substance, but it's not naturally found in the human body. So you have to wonder if you could be having a systemic reaction to the plastic or whatever it is. I don't think it's plastic, but it's something like that. The bag of the implant, or could you be having a reaction to the silicone itself? Is there any chance that the silicone is weeping? Honey, I'm so sorry, Maria. I think that you need to be very vocal. I would, if I were you, get the brand name of the breast implants that were used. You need to find that company. You need to go through all the safety data with that company and see what types of reactions people are having from that. I can imagine the plastic surgeon saying, well, they're not related, but bullshit. The proof is in the data. And I think what we need to do is we need to look at that actual implant and see if they've documented anything like that happening in anybody else. No, Maria, we don't have anybody flagging. I don't have any moderators in here. Hannah, sometimes the comments go by so quickly, I miss them. So please don't take it personally. Especially when I'm doing the Zoom meeting, I'm not looking at Facebook at all. Lorraine says, would PEA help pelvic floor dysfunction? No. What helps pelvic floor dysfunction is pelvic floor work and muscle relaxants. I mean, it might help reduce some pain, which might help calm the guarding reflex. But if you have pelvic floor dysfunction, you need to have a finger in your, you know what, working on those muscles. That's what fixes pelvic floor dysfunction. And Ramona, you say lidocaine installations have helped me for a few days when the insurance denies Elmeron. You know, we aren't really using Elmeron so much anymore, hun, because it's linked to really severe eye damage. So most people are transitioning off of Elmeron and have very quickly. There are over 100 lawsuits right now. We have some patients who are now blind from Elmeron use. And so that's when you want to look at supplements. Most patients are transitioning over to supplements or bladder installations instead. All righty. All right, my friends. I think it's time to call it. I'm going to give you your homework. For 15 minutes a day, I need you to do something for your spirit and your soul, especially now. Guys, you need some comfort and nourishment. So whether it is watching a church service, going and sitting outside in the sun, meditating, whatever, for 15 minutes a day, do something that will nourish your spirit, whatever spirituality you have. For 15 minutes a day, I need you to do something for your noggin. Like, seriously, let's get that knowledge level up on IC. So come on over to our website, read a blog, go to the ICA website, get off of Facebook. Don't rely on Facebook for your IC information. I mean, that's why I'm doing these support group meetings, to try to improve the quality. But some of the groups on Facebook are really scary, and they're giving really bad information out. So go to a reliable source. The IC Network, icnetwork.org, rated #1 in the world in 2 peer-reviewed medical studies by Harvard Medical School and the University of London. So if you could just read 1 article a day, they're not long. Like, seriously, do it. Let's get that knowledge level. I want you to be able to walk into a doctor's office and answer questions just like I do. I'm no different than you. I mean, I'm just a patient. Yeah, I have a lot of degrees, but I'm still a patient. The only reason I can do that is because I started reading. I started fighting back. I took control. I mean, how dare that doctor say I would forever be a burden on my family? I would always live in pain. He was wrong, and I proved him wrong. I want you to be able to prove people wrong too, but you got to improve your knowledge level. And for those of you who are older and you don't understand the importance of estrogen, read about it. You got to read about it. You know, estrogen atrophy, genital urinary syndrome of menopause. It's important. For 15 minutes a day, I need you to do something for your pelvic floor or your bladder. So make something bladder friendly, or go do your wand work, or go lay on your living room floor, as I need to do, and do the stretches the physical therapist told you to do. I don't need you to do big giant things. That's overwhelming. I'm talking little baby steps. You can do 15 minutes of stretching. You can do that. And then last but not least, I need you to do more than 15 minutes. I'd love you to do an hour of laughter and games and fun things, because the laughter modulates pain. And so this is where TikTok is great, as long as you're not on the animal feed. Oh my God, that's terrible. Okay, or YouTube videos or whatever. Do fun things. In fact, listen, has anybody played Among Us yet? I'm dying to put together an IC group that will play Among Us. You guys know what that is? So that's a game where you all log in, and each game is a mystery. There are 2 people who are bad guys, and it's like Pac-Man. And you kind of look like Pac-Man, but they're like little figures that run around. And you run around like a factory floor, and you have little tasks like putting wires together and stuff like that. But out of the group of 8 or 10 people, there are 2 people that try to kill everybody. And so they will, and it's all animated. It's hysterical. There's no blood or anything like that. As soon as somebody dies and somebody finds a body, a warning goes out, and then the microphone's open, and y'all have to talk to each other to try to figure out who the bad guy is. And of course, then the bad guys have to lie. And so it's hysterical. So if anybody wants to play Among Us, I've never played it. I'm dying to play it. We need, I think we need like 6 people or 8 people. Pop me an email, icnetwork@mac.com. Maybe we can try to set that up for, in a couple of weeks during the holidays. All right. All right, my friends. Love you, love you, love you, love you. You are not alone. If you are suffering in silence at home, I want you to pretend that I'm standing right next to you. And you've got a million brothers and sisters standing behind you. We are here for you. We are supporting you. You are not alone. Okay? We care. You got this. You're tough. And you're just going to get tougher and smarter. And one day we're all going to be able to celebrate. So, all right. I'll see you guys later. Have a good one. Love you, Donna. Patty says she's watched videos on YouTube of Among Us. Patty, if you want to do it. David, if you want to do it. Maria, you guys email me, icnetwork@mac.com. I'll put together a group. Let's do it. And the other thing I'd love to do is Cards Against Humanity. That's hysterical. Cards Against Humanity, IC version. Come on, we got to let it out. David, you play Among Us with your kids? That's great. Let's do it, guys. Let's do it. Email me, icnetwork@mac.com. Melissa says curcumin. You just got to try it and see how you do. Bye, YouTube.